host so that I'll be able to share my screen.
Madam, இப்ப try பண்ணுங்க madam. I have given permission to share. நீங்க உங்க PowerPoint share பண்ணுங்க madam.
It says disabled participant னு சொல்லுதுங்க
ஒரே
sir.
ஒரு செகண்ட் மேடம். ஒரே ஒரு செகண்ட் மேடம்.
Okay, okay.
இப்ப ட்ரை பண்ணுங்க மேடம்.
Okay.
Please try. இல்ல ஷேர் பண்ணனும் நாங்க பூர்ணிமா மேடம்.
என்ன சார்?
இல்ல மேடம் பூர்ணிமா மேடம் wanted to try and share. நீங்க ட்ரை பண்ணுங்க மேடம் இப்போ.
தோ பண்றேன் சார். Are you able to see?
நல்லா தெரியுது மேடம்.
Okay, fine. Okay.
இப்போ unshare பண்ணிடுங்க மேடம் please.
Yeah.
And I am sharing the YouTube link in the here in chat box as well as in the
இதுல பாக்குறேன் அதுல அதே வரும். வரேன்.
I have shared in both of you. Madam, we have 1 minute to go madam. Ready ஆயிடுங்க madam. சாந்தா madam.
டாக்டர் சாந்தா ஃபர்ஸ்ட் வந்து டாக்டர் சாந்தா தான் பேச போறாங்களா?
எஸ். சரி. ஓகே. எதுமா?
இல்ல ஃபர்ஸ்ட் நான் இன்ட்ரோ듀ஸ் பண்றது டாக்டர் சாந்தா தானே.
யசோதா. ஃபர்ஸ்ட் நாம வந்து ஃபர்ஸ்ட் வந்து now I will just welcome everybody.
Okay.
Then the தமிழ் தாள் வாழ்த்து.
Madam, request to everybody, please address Dr. Shanta as Shanta Narayanan today. Because we have Dr. Shanta from Cancer Institute also.
Yeah.
So, secretary as Shanta Narayanan.
இல்ல சார் செக்ரட்டரின்னு சொல்லலாம் சார் ப்ராப்ளம் இல்ல சால்வ் ஆயிடும்
இல்ல whatever but Dr. Shanta is there, let her not get confused on this issue.
Okay.
சொல்லுங்க சார். தம் ஐஎம்ஏ பிரேயருக்கு அப்புறம் we will have inauguration.
Okay.
By Madam Shanta madam, then I will say a few words, then our president's address, and then madam's talk.
Okay. Okay.
அப்புறம் மிச்செல்லாம் அப்படியே ஆட்டோமேட்டிக்கா வரும்.
மேடம் 2 மணி ஆயிடுச்சு ஸ்டார்ட் பண்ணிடலாமா?
ஸ்டார்ட் பண்ணலாம். இவர் ஜெயலால் சார் he said he will come at 3 o'clock.
Yes madam. அவர்
He's got some
CM கூட
meeting at 2 o'clock.
ஆமா.
So shall I start sir?
Please madam.
Okay.
சாந்தா மேடம் வந்துட்டாங்களா?
வந்துட்டாங்க மேம் வந்துட்டாங்க. அப்பவே வந்துட்டாங்க.
அதனால என்னோடதுல தெரியல. அதனால தான் பார்த்தேன்.
அவங்க அப்பவே வந்துட்டாங்க
மேடம்.
கொடையா இருக்கு. வந்தாச்சு. டாக்டர் சாந்தா மேடம் வெல்கம். சரி, we'll start.
Unmute பண்ணிடுங்க மேடம்.
Everyone, a very warm welcome to all of you. Medaling the president.
Done madam. Madam, go ahead. Madam, mute பண்ணிருக்கீங்க.
இல்ல சார், அன்மியூட்ல தான் இருக்காங்க. ஏதோ ப்ராப்ளம் ஆகுது.
Dr. Shanta Narayanan, unmute yourself please. Dr. Shanta, unmute please.
இல்ல என்னோட ஆடியோ சரியா இல்ல.
ஓகே பேசுங்க, இப்போ கேக்குறது பேசுங்க. Go ahead.
கேக்குது. சம்பத் குமாரி.
Yes madam.
சம்பத் குமாரி.
Yes madam. Yes.
Please start your prayer.
Please.
Yes, can you hear me madam? Hello.
Yes, yes, go ahead.
Yes madam. எல்லாம் வல்ல இறைவா, உலகின் சிறந்த மருத்துவன் நீயே, உன்னை மண்டியிட்டு வணங்குகின்றேன். உன்னிடம் இருந்து நல்லதும் சிறந்ததும் என்னை அடைய பிரார்த்திக்கின்றேன். எனது கரங்களுக்கு திறமையை தாரும், எனது மனதிற்கு தெளிவான பார்வையை தாரும், இருதயத்திற்கு இரக்கத்தையும் கனிவையும் தாரும். எனக்கு அளிக்கப்பட்ட சிறப்பு தகுதியை தக்க வைக்கும் எண்ணம், வாடும் மக்கள் படும் பாட்டினை சிறிதளவாது போக்கிட ஒன்றுபட்ட எண்ணத்தையும் வலிமையையும் தாரும். என் மனதிலிருந்து தகாத எண்ணங்களையும் உலகளவு ஆசையையும் அறவே ஒதுக்கி பணி செய்திட அருளுமாறு குழந்தை போன்று உன்னை சார்ந்து வேண்டுகின்றேன். எல்லோரும் மகிழ்வுடன் வாழ, எல்லோரும் நலமுடன் வாழ, வலி என்னும் தொல்லை நீங்கி அல்லல் செய்யும் இன்னல் நீங்க பேராசை பிரதிபலன் அகற்றி பிணி போக்கும் பெரும் பணி ஆற்றுவோம். தேங்க்யூ. செக்ரட்டரி மேடம்.
தமிழ் தாய் வாழ்த்தா மேடம்
போடலாமா சார்?
போடுங்க சார். போடுங்க போடுங்க. மேடம் உங்களுக்கு கேட்கவே இல்ல. We can't hear you at all. Dr. Shanta Narayanan.
Now, can you hear me, sir?
இப்ப பேசுங்க, அப்படியே பேசுங்க.
Can you hear me?
Yes, go ahead.
Okay.
Good evening.
Today we are having a CME on breast cancer awareness. Whole being the breast cancer awareness, we have stalwarts on
கேட்கலையே.
இன்னும் கேட்கல மேடம்.
Yes sir.
நீங்க ஐ திங்க் மைக்க பார்த்து பேசுங்க. நீங்க வேற எங்கயோ திரும்பறதால வரலையோன்னு தெரியல.
இல்ல
இல்ல மேடம், சுத்தமா கேட்கல.
Anvarasu, who is elevated as National CGP Secretary, and Dr. Rekha, past President of Poonamali High Road Branch, as the Joint Secretary, National CGP, IMA CGP. I request now Dr. Shanta Madam to inaugurate the function, and we will ask Dr. Jaya Soda to say a few words about Madam.
அவங்களுக்கு மியூட் பண்ணலையா? மியூட் ஆயிருக்கு பாருங்க டாக்டர் சாந்தா. அது
Dr. Shanta,
unmute
please. Madam, unmute.
I think yes. Just say inaugurate now, because
yes,
okay, I have great pleasure in inaugurating this very important meeting today on cancer awareness, especially breast cancer. Thank you for the opportunity, and I think it is going to be a very successful meeting because we have all joined together to conquer a problem that have been facing us over the years. Thank you.
Thank you, madam.
Thank you, ma'am.
Dr. Yasoda.
Yes. According to reports released by ICMR and National Cancer Registry Program of the National Center for Disease Informatics and Research, cancer cases in India are estimated to be about 14 lakhs in 2020, over 7 lakhs in women. Breast cancer is the most common one in women. the incidence of which is expected to be around 3 lakhs in 2020. Every 4 minutes, an Indian woman is affected. Women in 30 to 60 years of age are at risk. 1 in 28 women face the risk of cancer. Cancer survival becomes difficult at stage 3 and 4. More than 50% of women are diagnosed at these stages. Post-cancer survival reported to be 60% in India as opposed to 80% in USA. The reasons for this sad state is lack of awareness, poor early screening and diagnosis. The highest incidence is recorded in Kerala. Is there a strategy for prevention? Healthy lifestyle, exclusive breastfeeding up to 6 months, detailed family history, routine self-breast examination, screening program for early detection, awareness of facilities, availability of treatment centers are all vital for reducing the incidence and mortality from breast cancer of our women. Hence, as a first step, our CME is aptly titled Breast Cancer Awareness Program. The first topic is by Madam. Are you going to introduce further? She's going to talk, Santa?
You introduce her.
Yes. Okay. The first topic, lessons learned in managing breast cancer. We are fortunate to have Professor Shanta, a colossus in oncology, an internationally acclaimed lady to acquaint us with everything we need to know in a nutshell. She's the chairman of the Cancer Institute, Chennai, a center of excellence in oncology at the national and international level. Hailing from a family of noble laurels, she has dedicated over 50 years of her life to organizing care of cancer patients, training generation of specialists and scientists, involving philanthropists, and initiating palliative care. She had served as in WHO, Indo-US Collaborative Group, State Advisory Board, ICMR committees and task forces. She held the post of President of Indian Society of Oncology, Asia Pacific Federation, Organization for Cancer Control, and many more. She has presented over 160 papers, contributed chapters in oncology, delivered prestigious orations, and participated in international and national conferences. She is the recipient of major national and international awards. Ma'am, indeed, we are honored to have you in our midst. With over half a century of solid work in the field of oncology, you are the best person to tell us about lessons learned in managing breast cancer. Over to you, ma'am. Hello, ma'am.
Can I start?
Yes, ma'am.
Yeah. Thank you. Thank you for the introduction. When I joined,
we are honored, ma'am. We cannot introduce a person of your stature. We are really honored, ma'am.
Thank you for the introduction. And when I can tell you, when I joined the institute in 1954, we were the third cancer center in the whole country and the first one in Tamil Nadu. And there were very little information about cancer. Cancer was considered an incurable disease, fatal disease, and it affected only the old people. And much has happened over the years, 6 decades. There has been a transformation in the horizon, cancer horizon. From incurability, we have gone to curability. And not only that, much more, that today we are talking not only of cure, but of quality cure, and morbidity is involved, and cancer control. Today we are not in the era of cancer control, we are in the era of cancer prevention and early detection. Unfortunately, in spite of all the transformation and advances that have happened, late disease still continues to pose a problem. This is essentially because of the lack of awareness of people. And of course, we have had 1 or 2 data on the incidence of cancer, the commonest cancers in India. or cancer of the cervix, cancer in women, or cancer of the cervix, breast, and oral cavity. The magnitude of the problem of cancer is when we started in 1984, it was hardly 8 lakhs. Today it is 115 lakhs. The burden of cancer. We have very good data on cancer and the common cancers, women, cervix and breast together constitute nearly 50% of all cancers in women. Now, cancer of the cervix was the commonest cancer till 2002. But unfortunately, I do not know the reason, but 2002 we started going up. The cancer cervix, the trend between 2000.
Listen on that. I'll just put in my.
Pardon?
Madam, please continue, madam. There was a disturbance, madam. Please continue, madam.
Madam, please go ahead, madam.
Yeah. From 2002, there has been a change in the trend in cancer, and that has also given us a problem because cervical cancer was much easier to treat. Breast cancer is not that easy. Now, from what we had at that point of time, cervical cancer in 1984, when we had the first data, the incidence, the crude incidence, CAR, was 44.5. Today, it is 18.9. I think a remarkable change that has happened. But unfortunately, the breast cancer, which was 14.7, has now come to 24.7, and it is increasing. Now, the magnitude of the problem of NCDs, there are lifestyle program, lifestyle actually diseases, and I think we have every method to take care of it. And if we are failing, it is because we have not been able to reach the people, the correct people at the correct time. The next one. Cancer, the first thing that we have to do is dispel the myths about cancer. Cancer is not fatal. It is not, I think this is not the right side. Cancer is not fatal. It is not incurable. Cancer is curable if detected early. Pain is not a symptom of early cancer. Pain is a symptom of late cancer. Therefore, do not wait for pain. I think this information has to go to the public because majority of people say, I never had pain. And they have to be taught the 7 danger signals of cancer. If you go to any of the developed countries, every child knows the 7 danger signals of cancer. Here we do not know. Even the educated public do not know the signals of cancer. The vital component in cancer control at any site is awareness. These myths about cancer should be dispelled, and education must be extended, I believe, not only to the general public, but also to professionals. I think quite often we find that they are as ignorant as, not necessarily ignorant, but they are not aware of the whole truth. It will be very necessary for all women to be aware of the signs and symptoms, the methods available for early detection and prevention. And women must be aware of all the modalities of treatment that has made cancer treatment very acceptable. I think they do not know. But this acceptable treatment is possible only if they come early. And they must know early cancer is curable. Next slide. Yeah, I think this is the same that I have already repeated. They have the overall outlook for methods of treatment, because the methodologies in treatment are many and people get a little confused because there is today where they have access to the internet, and they see all kinds of information, and then they do not understand and come. So it must be the responsibility of the people, of the professionals, to give them the exact methodology that is available and what is possible and what condition. The methods available for early detection is important, and the options available for treatment. The next one. Now, education and access to health care. I think this is important. Women must be taught self-examination of the breast. A clinical evaluation of the breast is mandatory. This I want to stress again and again, because today technology is available for anything. Technology is taken. The clinical examination and evaluation is lost in the dark. Now, immediately a patient is complaining of pain or anything, mammogram, ultrasound. We do not know what it is. There is no clinical exam. The mammogram is done. And the routine screening, I think, is not good. We must have clear-cut guidelines on which the screening has to be done. Next one. I don't think we need to know the symptoms of cancer. Next one. The next one. Yes. No, இது பிராரம் இல்ல இல்லம்மா ஷார்ட் ஆயிட்டு சரி மேட்டர் I'm sorry. Delay. Now,
Okay.
Enhanced risk for breast cancer. Cancer in the first degree relative, there is a 3-fold increase, and cancer in the first 2-degree relatives 9-fold. I think this is important for people to know. Wherever there is a family history of breast cancer, I think they have got to be very cautious. The next part. The concept of health screening. No, it is.
The concept of health screening மறைஞ்சிட்டு இந்த useful end இருக்கு.
The concept of health screening is, it is useful in common accessible cancers, oral, uterine, cervical, and breast. Now, the concept of cancer screening is applicable only for cancers that are superficial. Deep-seated cancers cannot have. So screening is available only for certain types of cancers. It can be effectively reduce morbidity and mortality. It can detect 3 to 4 times more pre-cancers as cancer, and the curability rate is high and fatality rate is low. The next one. Next one. The potential for screening, which I already mentioned. So the next one. Yes. Screening is accepted as the method of screening is accepted as the final ultimate method of cancer early diagnosis, and especially for breast cancer. Any imaging, this is a thing that I would like to point out. Any imaging must be correlated with a careful examination by an experienced professional. Again, I want to reiterate, because it has become a fashion to order either a mammogram or an ultrasound or CT scan or a PET scan. Ultimately, their reading, ability to interpret it is going to be very important, especially mammography and ultrasound of the breast, and the interpretation by not only the ultrasoundologist, but it must be a combined examination between the ultrasonologist and the clinician together. Next one. The mammographic screening, we normally add ultrasound because of certain deficiencies that we find in the mammogram, especially in the older people, and the interpretation is very, very important. Many a time, people have mammograms done 2 years ago and say there was nothing and now I have a cancer. When you go back, there is some abnormality which we could have diagnosed cancer at a much earlier stage. The next one. Now we have multiple methods. Technology is improving fast, but the unfortunate thing is everybody is not trained in every technology. The technology is misused. So we have digital mammography, contrast enhanced mammography, magnetic resonance imaging, and digital breast tomosynthesis. Every one of them, I think very few people are fully trained in every aspect of it. And the people simply write down and say, ask for this, when there must be a very clear indication for everything. Next one. No. I would like to reiterate, especially to the general practitioners, mammography should be used only if absolutely necessary. Mammography, unnecessary mammography should be avoided, especially in the young women. It does expose them to radiation, and I think we should try as far as possible to reduce it to the maximum possible. Mammography should be done only after a clinical examination. Now the reverse happens. Everybody goes mammography done, clinical examination either done or not done, because they say mammography, nothing. Clinical examination is not done. There are many, many times that is where the deficiencies of technology. Mammography at sometimes need not show a tumor, which can be done with a clinical, just as the reverse can happen. Clinical examination followed by mammography, and both are most important in evaluating breast cancer screening. Next one. Now, the benefits of screening program, there are a lot of material, lot of trials that have been done. Cancers detected in the screening programs they're very small, can detect pre-cancers, non-palpable tumors, can detect carcinomas in situ. Treatment intervention can cure the individual. The potential benefits, of course, as I said already, is the improved survival, less aggressive methods of treatment, and reduction in cost. The reduction in breast cancer morbidity is 30%. Reduction due to screening is about 1/3. Reduction due to scientific treatment is 2/3. What I want to highlight here is, by detecting early disease, you have not cured the disease. They must have proper treatment. It is a scientific advance when you're able to get an early tumor, where you're able to conserve the breast. Breast conservation has dramatically changed the attitude of women to cancer. So I think we must be able to give them just treatment when we see early disease. So proper treatment is as important as early detection. Next one. Now, there are some guidelines for breast screening for women. Self-examination can be monthly. I think some of this is overdone. I think any married woman over the age of 25, 30, breast self-examination must be taught. Clinical breast examination once in 3 years, but that is, they go to a doctor for that. Mammography every 2 years, and checkup, which I have said, but more and meticulous examination in high-risk women with family history of breast cancer. It is important that mammography should always be done along with clinical examination. One without the other is inadequate. I would like to mention a few things on my perception of the role of a primary care physician. Obstetrician and gynecologist have to be the primary care physician for cervical and breast cancer. You have to take the opportunity. Every woman goes to a gynecologist for obstetrician for during childbearing, and for any other complaint they choose the gynecologist. You have to take the opportunity to educate these women about the signs and symptoms of cervical cancer and breast cancer, and teach self-examination of the breast. I think this is an opportunity to be done, because every woman, I mean, there is no woman, I think generally, majority, 90% of women go to the gynecologist. The one other major issue that I, over the years of experience, and I've been seeing in the OP, I would like to mention, which may not be very palatable. Many a time today, DGOs, MDs in gynecology obstetrics do not do a pelvic examination. When a woman goes for a vaginal discharge, they order either a scan, ultrasound, or whatever they feel they have to do. I think this should be avoided. A clinical examination is vital. Clinical examination is must in every patient. And I think after the clinical examination, of course, people who are here will know about the visual inspection, vaginal smear if VIA is abnormal, colposcopy wherever available, and at the same time, every gynecologist after a gynecologic examination should examine the breast as well. Now, between the early, I just like to mention a few things in the management of breast cancer, because this has been essentially for awareness. A comprehensive diagnosis and staging is important. Breast cancer, everybody, they think immediately, they think either surgery or chemotherapy or radiation. I think a comprehensive examination, especially biopsy, and a very clear pathologic evaluation, pathologic stratification. Today, molecular evaluation has given us a lot of markers. Markers must be a part and parcel of study, and before the treatment for breast cancer is undertaken. You have to think in terms of comorbid conditions, because large majority of them, and especially, this is one of our observations, the diabetics are especially prone to breast cancer, and wherever there is a family history. So taking a good history, prior history, family history, that there has been any person with family history, even one generation earlier, is going to be important. Now, I like to show a few survival in breast cancer. Survival in breast cancer has increased over a period of time. If you see in 1957, what was 30%, today is almost 70%. And if you go, I mean, I don't want, this is not a lecture on cancer breast in survival, but if you go by stage of disease, it is much better, because you can get a very high survival data. Now, I would like to mention that early diagnosis is very important. Early diagnosis, we must dispel the myths about cancer. We must increase the awareness of the public and women about what are all possible. All treatments is not the same. I think they must understand the different modalities of treatment and the different survival data that they can have. Today, the question of seeing the internet and not understanding what is right and what is wrong should be avoided. I think they should understand that they must go to the doctor for evaluation. I think as far as early detection and prevention, I have mentioned whatever is possible as far as breast cancer is concerned. Now, one of the other things which I've forgotten to mention, cervical cancer has gone down, breast cancer has gone up. What is the reason? I think we've been able to do a lot of studies in Tamil Nadu. It is directly related to education. The illiterate has the highest percentage of cervical cancer, and the highly educated people have the lowest. Similarly, the breast cancer is the reverse. But this is changing also. Even in the uneducated, the less illiterate, breast cancers seem to be increasing. I think the reason for it have got to be seen as to why it is happening. Breast cancer is curable. Cervical cancer is curable. Our cervical, the important thing in doing this early detection, you have to have a complete follow-up of the patient you have treated and showing the patient, showing the relative or showing the patient who is coming afterwards that this patient has cancer, she is cured, is important. That we have what is called the breast cancer survivor clinic, cervical cancer survivor clinic, where they are able to get a kind of a boost from them and get over the fear and panic, because we must dispel the stigma about cancer. We must dispel the fear and panic of cancer. And for this, the ambassadors will be the survivors. And I think one of the major things that can be done is to get the survivor to talk to them. They believe them more than the doctor. I think that is important. And we have come a long way in cancer management, curability, and the transformation from conventional treatment to precision treatment, translational research, and then we have chemotherapy. Chemotherapy in breast cancer is something that is being misused. I think it has to be used only where it is indicated. Hormones are there. A combination of hormones and chemotherapy has made a remarkable dent on the overall survival. Today we have other immunotherapy and the Herceptin and other drugs which are very, very expensive, and I believe many of them are not curative, and I think it is necessary for the doctor, the medical professional is important in taking a responsibility to make the treatment affordable. If the cancer treatment is not affordable, I think it is essentially a part of the responsibility of the physician. I think the technology and then the type of treatment given should conform to the way that it can be made available to the patient at large and to the poor. I think I have tried to do as much as possible. 10 minutes. Huh? How long has it taken? More than 10 minutes? I'm sorry. Thank you.
Thank you, ma'am, for an enlightening talk on breast cancer. Your insistence on regular, meticulous clinical examination, a detailed family history, and a focused ultrasonogram and mammogram of the breast, along with immunohistochemistry is heartwarming. Henceforth, we women doctors of IMA Chennai South assure you, ma'am, we would do everything in our force to do clinical examination of every woman we come across in our day-to-day life, ma'am. Thank you so much for the enlightening talk, ma'am.
Dr. Shanta Narayanan, unmute, please.
Thank you so much, madam. On behalf of IMA Chennai South, we thank you for your wonderful lecture. Thank you so much, madam. President, you want to say anything? Sir?
You want me to say something or no?
Say a few words.
If you want me to say something?
Yes, sir. Yes, sir.
Yes, okay. So in fact,
sir?
What is it?
Yes,
thanking madam, sir.
Yeah. So we have the very exponential talk by the stalwart. The name, the cancer research and Dr. Shanta go together. And we had the greatest opportunity today. I think it is the initiative of Dr. M. Kanakavel. And we thank Dr. Kanakavel and Dr. Shanta for doing this for us. And this is the first time Dr. Shanta is addressing our branch, I think. I'm extremely thankful and happy for this response. And we have other stalwarts today in this meeting. Dr. C.N. Raja, the president of the state president, and Dr. Jayalal, the president-elect, the national president-elect for the next year. The C.N. Raja is also vice president-elect for the next year. And I start this, my talk with the congratulatory messages on behalf of myself and the branch members that we are very, very happy, sir, that you're all gone to the other next level, like Narendra Modi going from the state to the center. So you've gone again from state to the center, and we are very, very happy. And the second happiness is that the very working and very vocal president and Dr. Jayalal, I know, is a very, very vocal man. And these two top people have gone to the top level, which will benefit all the members of the IMA, not only the IMA Chennai South. And we are extremely happy that people have gone from Tamil Nadu. And I wish, on behalf of the association, I wish you all the very, very best. And something to happen like this, we have the very good organizing secretary, Dr. Ravi Kumar, at the center, like our own secretary, Dr. Shanta Narayanan. And things are going so beautifully well. And the efforts they have all taken in this COVID era with the government has really proved that they are great and they are really vociferous and they got many things done. And also we have Dr. Ramakrishnan, the president-elect of the state of 2020, of the 21. So we welcome all these stalwarts today. And we have a very tight program, and I don't want to keep on engaging you. We have Dr. K.R. Govindaraj, Reverend Sister Anne Asha Anne, and Mrs. Rama Ravi, one of my very good friends and a cancer survivor, a very vocal, straightforward survivor, and Dr. Somashekar, the president of the Indian Association of Breast Surgeons. So this program is going to be a show of the stalwarts, and we are going to be benefited by this. And we have a very, very tight program. So I think we can't be finishing by 5 o'clock. So please, all of you hold on and stay till it is till the end. And I'm sure it will go beyond 5 o'clock because the people have to deliver their messages. So I welcome you all and please enjoy this evening.
Yes, thank you very much, sir. The next one is I request Dr. Ravi Kumar. Is he there? Dr. Ravi Kumar, sir?
How do we get on?
Dr. Ravi Kumar?
Ravi Kumar, illa madam.
Dr. Ramakrishnan? He was there. Ramakrishnan was there.
Ramakrishnan sir irukare.
I think. May I take leave, please?
Thank you so much, ma'am. Thank you for the honor bestowed on us, ma'am. Thank you.
Our humble pranam to you, madam. Humble pranam. God bless you. Thank you.
Humble pranams, madam. Sir, Ramakrishnan sir irukara?
Next venna Dr. Purnimavum Dr. Kanagavelum pesittume Shanta.
Dr. C.N. Raja has to speak, ma. Dr. C.N. Raja? Raja was there. All of them had come. I saw them. Dr. Raja, sir? Sorry, okay, we'll go to the next one.
Dr. Purnima?
Dr. Ramakrishnan Kapram, Mission Jailal will come late. Then the impact of breast cancer prevention by Dr. K. Govindaraj.
அவரோட சிவி நீங்க படிச்சிடுறீங்களா சாந்தா? என்கிட்ட இல்ல.
Madam, it is there.
NT only. Our Kanakavel will read. Yeah.
Okay.
Dr. Govindaraj?
Yes, yes.
Dr. Govindaraj sir is with us.
Welcome, sir.
Yeah.
Welcome on behalf of IMA Chennai South.
Welcome, sir.
Thank you, madam.
Good afternoon, madam. Am I audible, madam?
Yes, you are.
Yeah. Warm welcome to all the IMA members, leaders of Chennai South, state leaders, central leaders, and Shanta madam for joining us today. In fact, I have proud privilege to introduce Dr. Govindaraj sir. He is having a chain of hospitals in Trichy. He also has a very long foundation. Instantly, he also has a cancer care foundation, which is now running for the 15th year successfully on various programs. They concentrate on awareness creation. They concentrate on screening issues. And it was the first South mobile mammogram unit, which was created, conceptualized. So rather than bringing the women to the hospital, the Vishwanathan Hospital had a vision to take the screening services to the village center. And in fact, their cyclothon, their marathons, and their awareness programs are globally renowned. And now they have crossed more than 2 million miles clocking for this year. With that, to come back to the main introduction, Dr. Govindaraj is a surgeon. He's got his FRCS from Glasgow, and he is a very ardent teacher. For the past 24-25 years, he's been educated at various centers after his MS, and he is a proud student of Professor B. Krishna Rao sir. And later on, he took both endoscopy and laparoscopy to national and international strides. Before even associations took the responsibility, at a level 2 city, Dr. Govindaraj started educating the next generation in training of endoscopy and laparoscopy. Dr. G. Vishwanathan Specialty Hospital, Dr. G. Vishwanathan Hospital has an exclusive oncology center. They have a college of nursing, and they were the first to start an exclusive COVID center during this COVID pandemic. And they had tough challenges, but then they were able to withstand the challenges, and their results were exceptional and better than many corporate and government hospitals. Dr. K. Govindarajan sir is blessed with 2 children. His wife, Madam Malini, is a senior obstetrician and gynecologist. Both the children are doing their medicine. And he has been associated very keenly with Association of Surgeons of India as well. And currently is the Vice President of the Indian Association of Gastrointestinal Endoscopic Surgeons. On behalf of the IMA Chennai South and all the leadership of the IMA State and Central, I take proud privilege in welcoming Dr. Govindaraj sir. Please share your experience, sir, in your path on breast cancer awareness and screening programs in various localities around your hospital. Over to you, sir.
Thank you, Dr. Kanagavel, for that wonderful introduction. And first of all, I should thank Chennai South for allowing me to share my experience in this August portal. And I'm so happy to talk after the great Shanta madam. And we have been associated with the Institute of Cancer, Adayar, for almost 5 decades. And it's so wonderful for all our breast cancer foundation programs. Dr. Shanta madam was the one who inaugurates it till last year. And I was so happy I met her last year in the 94th birthday and invited her. And she came for our last year's Mammo Night program, and she was the one who wonderfully inaugurated the program. So thank you, Chennai South and IMA of Chennai South and the President, Secretary. And of course, I should first congratulate Dr. Jayalal on becoming the National President-elect now, and Dr. Raja our Tamil Nadu State President, and Ravi Shankar, our Tamil Nadu State Secretary. Thank you, sir. And our journey on the breast cancer started probably my mom. She again, her name is the same as Dr. Shanta, so the affinity started that time. And she passed away in 1995 with because of breast cancer. That was the time we used to think, because that was the time in the initial phases of breast cancer management. There are a lot of differences between what is being treated today. For a early breast cancer, at the time, chemotherapy was not being given. And my mom was a classmate of one of the senior oncologists of Chennai, now Dr. Subramanian uncle. And so it happened. So in 1990, when she started, she was diagnosed of breast cancer in stage 1. At that time, the teaching in the books were no chemotherapy for breast cancer, stage 1. But we continued with the chemotherapy. But as you all know, the tumor biology behaves differently with different people. We were not lucky enough to have her beyond 1905. That was the time I was thinking why we should not do something for the community to teach the people or to bring to their doorstep the innovation and the inventions in breast cancer management. And then in 2005, we inaugurated our Dr. K. Shanta Breast Cancer Foundation. It was none other than our esteemed guest today, Padma Vibhushan, Padma Bhushan, Raman Magase Awardee, whatnot. And she has got all the awards the country can have. And she was the one who inaugurated it in 2005. And the initial phase of breast cancer foundation was, we were just going around the city, the towns, the villages, and my wife was the one, Dr. Hemamali Gograj. She was a gynecologist. She was just doing camps there. And the important thing which we used to tell is the breast self-examination. That was the most important thing which we used to teach there. And at that time in 2005, when we started, we had a lot of this MSW workers, students who came to us. We did a survey among the rural and the urban public of Trichy and the neighboring villages. One stark finding we found out was the rural public were willing to learn, and their awareness about breast cancer was much better than the urban public. So we wanted something to be done to take the treatment to the masses. That was the time we wanted to teach them self-examination, and much more than that would be the breast mammography. In 2005, breast mammography was an expensive tool, not available even in a lot of the metros. It's a lot of the tier 2 cities itself. So how do you take it to the next level? Then we had to approach various NGOs to help us at the time. And 2006, that was the time we wanted to do much more to the village people. At that time, our village people were all glued to the television. They were all glued to the serials. So we produced a serial of half an hour. We had major actors like Vivek, Pallavi, Lakshmi, Sneha, all acted in this. And 2006, and again, Dr. V. Shanta Madam came to Trichy. She released the first copy of that CD, which we used to play even today for all our mammo camps. And it was received by our by the Vice Chancellor of the Bharatdasan University. And at that time, we had a surprise to us. We had an appreciation letter from our then President, Dr. APJ Abdul Kalam sir. It was the most motivating letter that could happen to me in my entire life. And then we started having a lot of Pink October celebrations. And as you all know, Pink October is nothing but a breast cancer awareness month, which is celebrated all over the world. In SBCF, what we did was celebrating the month is not only awareness programs by walkathons, breast cancer, conquerors meet, marathons, mammo night, and a lot of things were being done. And a few of the things is initial 2005 to 2010, we started doing a small walkathon, that is walk across river Kaveri. We used to cross bridge Kaveri. We used to do it 2-3 times in a month of October, and just to create an awareness for breast cancer. And then we started doing the breast cancer conquerors meet, who are all treated, and the patients who have been cured of breast cancer. We brought them to the stage and we highlighted their journey. They used to talk to the patients there. And we asked one of our celebrity survivors or conquerors, Gautami Madam also came, and she addressed one of the gatherings there. And the Vice Chancellor of the Bharatdasan University, Mrs. Meena, she was one of the part of our foundation who helped us doing all these activities. There on the left slide, you can see her. And apart from this, we used to conduct a lot of competitions in the schools and colleges on breast cancer awareness. And then we used to bring the top 3 of each class and then donate them with gifts. And these are all the activities which we are just doing just to create an awareness for breast cancer. And this was going on. And 2010 to 2018, our foundation started doing a run called the Mammo Run. It was a half marathon and a 5K and of course a 21K marathon. And till 2018, our numbers started increasing. It came up to almost 10,000 people were participating on a single day in Trichy. And we had celebrities coming and giving prize away. And it was a wonderful event. We continued till 2018. And then we started seeing marathon was becoming more commercial in a lot of aspects, which we didn't want to do. We want to do something different. And in 2019, we started doing the breast cancer campaigns by creating a hair donation campaign. And 2019, you can see on the left, she's a breast cancer survivor. She donated her hair for another person for whom we are making a big. And like that, we can see a lot of people who donated that during the breast cancer campaign in 2019. And 2019, we did a different event to create an awareness. We did a BBC ride. That's called the Beat Breast Cancer Ride. We collected motorbike riders from all over India. We had 124 women riders who came to Trichy. They were riding the bike for 20 kilometers. And we created a kind of a noise around Trichy for breast cancer awareness. People are wondering why women riders are riding. Then started the hushes of how breast cancer awareness can be created. Then the 2007, it was during one of my talks, which I went for Korea, I visited a bus in Seoul. And that was the first time I saw a Mammo bus. And this bus was donated by a company called Johnson & Johnson. And it was done to promote an instrument which the Johnson & Johnson promoted at the time called a mammotome. I don't know how many people know an equipment called mammotome. Mammotome is a device that is used by the radiologist to remove small fibroadenomas or any benign disease in the breast without making a big scar. And this Mammo bus was used by Johnson & Johnson to create an awareness so that they could pick up early lesions. At that time, I thought that then we should do something of this kind in India also. At the time when I inquired, there are only 2 Mammo buses in the entire country that were in the North India. And those 2 Mammo buses were becoming stationary and they were not at all becoming mobile Mammo buses. So what happened was at the time, the Mammo bus, which was, we wanted something which is go around the cities, real villages of Tamil Nadu. So I approached the biggest NGO of the world, that is the Rotary. And Rotary Club of Srirangam was willing to be a partner with us. And then you can see the then governor of Rotary district of 3000, the late Mr. Valliyappan was so into about this bus and our project. Then I went to a few of my conference visits. I met a Rockville Rotary in US, that is near Washington, DC. I met Dr. C.K. Deenan, who's an alumni of Madras Medical College, and Rachel Blair, who is one of the chairs in the Rotary. The president of Rotary International, Mr. Ravindran, who hails from Sri Lanka, he was also very upbeat about this project of us. So that was the time. In 2000, I subjected my willingness to run this bus. And in 2012, this Mammo bus became a reality. Then who will be inaugurating the bus? None other than our beloved Dr. V. Shanta Madam. In 2012, our Mammo bus was inaugurated in Trichy, and Ravindran, the president of the Rotary International, came to inaugurate the bus. And 2012 onwards, the Mammo bus started traveling all over Tamil Nadu and the southern states. And one of the camps was visited by Seshashahi, the chairman of the Leyland company. And we had a very old truck pulling the bus. And so he donated the truck, a new Ashok Leyland truck, to pull the bus so we could reach far off places. Even we have been to Nilgiris also, because our older bus was not able to travel such high. And how a mammography camp is conducted. The previous day to the camp, the bus is taken to the site where the camp is conducted. So we have doctors, dedicated doctors, we have dedicated nurses who visit the campsite, and they meet the women folk in that village or the city where they are going to perform the Mammo bus campaign, and explain to them by either pictorial or a videography. And they explain to them how a breast self-examination is to be conducted. as Shanta Madam was saying, mammography comes only after a breast self-examination. So first our motive is to teach them all breast self-examination. And after teaching that, we used to ask those the women folk there, their willingness to get screened the next day. And once it is enlisted, the next day morning, our screening will start. We can do a maximum screening of around 70 women per day. And in this mammography campaign, we have crossed the nook and corner of entire Tamil Nadu. We have gone beyond this also. This is an old picture. And we have gone to even Karnataka, Andhra Pradesh. We have started screening there. And a small statistics of our screening, what we have done from 2012 to 2020 is we have conducted around 250 breast cancer screening camps of mammography. We have educated 205,000 women folk on breast cancer awareness, and their breast self-examination has been taught all these 2 lakh people. And we have screened 18,589 women folk. Out of this screened 18,000, we have detected 22 cases positive. What happens after we detect 22 cases positive? If we have done a screening at Kayalpatnam, you can't ask them to come over here for treatment. We identify a hospital which is in a nearby town or a nearby village which is versatile in treating cancer. Then we subject these people, make sure that these people attend the cancer clinic of that, and proper treatment is there. And thanks to all our CML health insurance scheme, we are able to treat those 22, out of which 1 patient we have lost in this so many 15 years, and remaining 21 are alive. So in this way, we are at least happy that we have detected 22 early breast cancers. And this is the small statistics. I think whatever is being done by our foundation, we don't need just one mammo bus or 2 mammo buses. Not enough. We need hundreds of mammo buses for a population of our country. And we need not only mammo buses, we need to have good NGOs which are dedicated to augment the burden the hospital takes when they are screening or treating a patient of breast cancer. And still today, I know many of you will be seeing locally advanced breast cancers. Why do these locally advanced breast cancers are coming? We have to educate the public in how an early breast cancer can be detected. So coming to the last slide, let us fight together to detect the breast cancer. Thank you again, IMA South Chennai, for giving me this opportunity. Thank you.
Thank you, sir. Now I request the Secretary Madam and President sir to formally thank the invited speaker. Jailal sir, welcome sir.
Thank you. Welcome,
Thank
sir.
you for joining, Amit
Sir, congratulations, sir. Jailal sir.
Thank you, sir. Thank you, sir.
Thank you, sir.
Thank you very much, Dr. Govindraj, sir.
Thank you, madam.
I ran the Pinkathon when Madam conducted the marathon in Chennai.
Okay.
For the 60th year. I do 10K regularly. So I ran the Pinkathon cancer detection only.
This year being the pandemic, we couldn't do any marathon or any kind of an event. So we have devised a unique event, as Dr. Kanagalvel is saying. We have started a pink cyclothon. What we have done is we have crossed 2 million miles in pink cyclothon. It's a virtual event. There are people participating all over the world on this pink cyclothon. You can walk, you can run, you can cycle, and all the miles are added through an app to this. So we have crossed 2 million miles for breast cancer awareness.
Congratulations, sir.
Thank you, madam. Thank you.
Welcome, Dr. Jailal, sir.
Thank you, madam.
Is Dr. Ravi Kumar there? Dr. Ravi Kumar there? Has he come? Dr. Ramakrishnan, sir?
Hello, good afternoon.
Yes, sir.
Sorry,
Dr. Ramakrishnan, sir? Is he there? Dr. Ramakrishnan irukara? Sir, illana we'll ask Dr. Next one is Mission Breast Cancer by Dr. Jailal. Yasoda? Yasoda, madam?
Sir, a hearty welcome to you, sir, Dr. Jailal. You have made us proud. Being elected to the highest post of national IMA Is it the first time such a honor has been bestowed on a deserving Tamil Nadu doctor? We are not sure. Around 4 lakhs of IMA doctors of India are solidly behind you. He is going to talk on Mission Breast Cancer, the IMA perspective. He is a professor of surgery from Tirunelveli Medical College. He has been the he has many urgent tasks before him, namely prevention of mixopathy, protection of doctors and institutions against violence and vandalism, worthy health insurance for doctors, to mention a few. He is going to divulge IMA perspective of Mission Breast Cancer. I welcome you, sir, to deliver your proposals for the mission. Over to you, sir.
Yeah, thank you very much. And indeed, it is a great honor and privilege to be with you all. My great academic friend and great organizer, Professor Dr. Kanagavel sir, has asked arranging this program and asked this. And another very veteran leader, Sandha Narayan madam, even at the age when she is motivating the people to do the exercise and by her the marathon level of doing activism, yogas, and all that is still she has become one of the pet name among our members of Indian Medical Association. And I am also seeing a lot of distinguished members. And in all these midst, probably on this month of breast cancer awareness, I'm extremely happy that South Chennai branch is taking up this project of bringing awareness on the breast cancer. Indeed, it is a vision and objective of Indian Medical Association. Is whatever the diseases which we can prevent, the maximum possible extent that we need to adopt all these steps which is prevailing to help the people to prevent the occurrence of the disease. For that, we need a great awareness on the possibilities, the causes, and how it has been creating. Fortunately, today in the medical arena, we were able to disseminate and we were able to identify, and we know that what are the factors which is causing the mostly, we know beyond our capacity also that something can happen, but most of the times and what is happening that we all are aware of that. So it is our priority which we are taking up the prevention of the cancer. More so with an empowerment of the women doctors in the society. And we feel that Indian Medical Association, it is the responsibility of Indian Medical Association to talk more on the breast cancer awareness program. Because we firmly disease, the two diseases, one is the colorectal malignancy and the breast cancer. And if we can take preventive measures, definitely we will be able to succeed in bringing down the diseases occurrence in that.
Sir, you are gone to mute mode, sir. Please unmute yourself. Yes, sir. You're okay, sir.
Okay. So, Indian Medical Association feel that it is, though it is all our doctors in the same, but in the modern era, women doctors, as the number is increasing, and they will be able to reach out to the youngsters much more better than the gents doctors, and so that they will be able to propagate this message. With that mission, with that idea that we are strengthening the women doctors wing of the Indian Medical Association, and we have given a major project to them called the Mission Pink project, which includes the breast cancer, and also the menstrual hygiene and anemia related diseases. But the focus is on the prevention and the early detection of the breast cancer. Is one of the prayer project of the Mission Pink Health. That is a very, very vibrantly and with widespread activity which Indian Medical Association is doing. And everywhere in the society, the doctors are respected, at least to their mind. And they also have, whenever a doctor is saying something, they will listen to that. So, but now the knowledge of prevention of the breast cancer solely rest upon almost all the Western studies has come. The two events which we can all do, one is the self-examination, and the second one is the mammography, if it is possible at the level. But self-examination, if the studies across the country shows it is less than 10 to 15% of the people really know, are aware, or know how to do that in a proper way. So that is the responsibility which IMA is taking forward. And at least we are now instructing all our branches across the country. We have nearly 2,500 branches, and we have a very strong force of the women doctors that ensure that in your village, in your area, under your the area of your branch, that you are ensuring that everyone, lady of the college students may be writing for the college days of the 20 years of age, and they must be able to know how to do the self-examination and how to diagnose the red flag signs and adequately report to the concerned doctors in that term. We should also know, and we should not, along with that, the breast cancer awareness, we also trying to put them on the mental health awareness also, because we all know for sure for the 90% of the mass, the lesion which is occurring in the breast are benign. And it is nothing to be worried, only the 10% are malignant, but the malignant we need to early identify. But that kind of things can be come across only when the self-examination. So this is one of the major project which you do, because of course on the, as I have told earlier, and all the other 5 components of that, anemia detection, menstrual health hygiene, mental health hygiene, and the sexual behaviors, all this will be also taught with that. But the emphasis will be on the focusing and training our people on the breast self-examination. That the next area which we are going to train the people, and this is a survey which we conducted among our doctors in a huge gathering of nearly 300 doctors were there. We asked them, and how many of you as a doctor will allow your wife or one your relative subject to the mammography as we are advising regularly? And hardly, it was painful to see less than 5% of the doctors should be very firmly say, yes, I follow the protocols and I allow my wife or my relatives to undergo the mammography. Also still among doctors, and we are not coming to the incoming terms with this perspective of the mass screening by the mammography. So this is another area which we are giving as an health hygiene, because we are now talking about the physician heal thyself concept that we are going to promote among all the doctors, because what we see is the worst patients in the world are patients. So then their relatives, and we have seen many renowned surgeons and many renowned physicians come to us with an advanced stages of malignancy and advanced cases of the debilitating disorders, which we are not doing the preventive early prevention. So now we are becoming a mandatory point to all the our doctors in the society to see that, and we are enforcing the mammography findings. At least when you are having some suspicion or some suspicion, or when you have the self-examination, you are finding something, help them, promote them, encourage them, and empower them. Today, we are not able to see that much people are coming for the mammography because the family support is not being given. The lot of psychosomatical events are taking place. So that is one area we are still further concentrating on. So this is the 2 major tools which we would like to adopt in the Indian Medical Association. One is the self-examination and making itself susceptible to do the mammography examination available. Third, we know I have a firm believing all 75% of the causes of the NCD, non-communicable diseases, including which comprises only the 4 diseases, that is diabetes, hypertension, cardiovascular, and malignancy and respiratory, and it has only the 4 causes for that. And all the 75% of the causes of the death today we are experiencing as a virtue of these non-communicable diseases, including the breast cancer, is only the 4 major major habits which we adopt. One is alcohol, second one is the smoking, third one is obesity, and the 4th one is junk foods. So these 4, obesity or the unexercised body, especially in the postmenopausal woman where there is a fat is depositing, and that is only the fat which is available to have the increased estrogen level in the body. And whenever you have an alcohol which has a direct stimulant effect on the oxytocin or oxygen,
too much echo. Too much echo.
Well, sir, I think they muted everyone. Please unmute yourself, sir. Sorry, sir.
Okay. So these.
Sir, again, I think they've gone to mute mode, sir. Where's yes, sir.
Okay. So alcohol, smoking, junk foods, and obesity. These 4 are the preventable cause of NCD and also the are the also very important preventable cause.
We cannot hear. There's too much echo, sir. Voice is going on.
So Indian Medical Association, and we are now forming a coordination with other service organizations, especially Rotary International, Lions Club, and Weissman International. We have now signed an MOU with all these organizations to promote that preventable NCD habit, because that doesn't need a doctors alone. And this habit is to tell somebody that do not drink alcohol, or tell somebody to not to smoke and fit onto a body feature. It is not only the responsibility of the doctor. Of course, it is a responsibility, but there are a lot of good-minded social service organizations. And when we get the support of them, when we also take them into the journey, I'm sure the impact is going to be a great. So that way, Indian Medical Association, the third concept which you are now adopting is the preventable causes of lifestyle modification, which we can endanger, which we can promote among the public, is alcohol and smoking, and this we are also now promoting among that. So this is on the preventive side, these three offset we are doing. But then comes the early detection and the promotion and the affordable, accessible, and quality oriented treatment made available to the people. And the IMA is also working with the National Accreditation Board of Hospitals and the quality enhancement of the hospital and ensuring the patient safety in the hospital. So this is a priority concern, especially in the cancer therapy, or especially in the therapy wherever there's a primary health center, or right from the medical colleges where these people are going to come. And we are now ensuring that every sector will come up to the certain quality orientation. And the concept with which we are talking with the insurance sector is, it is not that some of the hospital will have the quality so the people can choose that hospital. It is not so, because that we want to make that every hospital will come up to the quality oriented, and nearby hospital the people can choose at least for the early protocol based treatment. That is one thing which we are lacking in our country, is the treatment which is offered by a surgeon at Kashmir and the surgeon at the Kanyakumari is not going to be the ideal, because many times it is getting changed. That many times they are not following a standard protocol, and we have only the NCCN guidelines or some standard guidelines, but which may not be fit into the Indian standard. So we are now working with another association and respective organizations where the protocol based treatment schedule or the uniformity of the treatment schedule can be brought into that. We had a special meeting with the Ministry of Health, and we had a meeting with the former all other organizations to ensuring that a protocol based treatment is going to come. And especially on this breast cancer, and we are going in the process of Indian Medical Association is the process of bringing out a Indian standardized protocol for how you are going to go ahead with what you are going to do with the people, and how we are going to manage. Even in some of the high-fi academic classes, when we are doing, there is still a lot of controversy is persisting on that, and what to do, what not to do, when to do FNAC, when not to do true cut biopsy, and who wants mammography. All this is a debatable one. But there must be, at least to some extent, it is a difficult job in India, such a vast country. But Indian Medical Association will take the responsibility to work with other organizations, other academic wings, and so that we will be able to bring out a community-oriented, a patient-friendly, but quality-oriented, a protocol which will be able to afford and extend the treatment. And Indian Medical Association also thank the governments of India and the government of Tamil Nadu for bringing the comprehensive health insurance scheme, where these treatments are covered. So no one can now say that without money that I am not able to do that treatment. It is only the mindset has to be changed. And when the people are rightly motivated, when the people are encouraged and empowered to take the appropriate treatment, I'm sure the benefit of all the modern advancements can reach the people, because if they do not have money, we have a government institutions to provide it free of cost. There are certain CM insurance scheme is there, or if there is no accessibility, still they will be able to get some contacts where they can reach to the right place. So we need to be important that this is a fourth component which I want to stress upon. Finally, I just want to upon so far Indian Medical Association is considered as one of the body which is working hard for the social and professional welfare of the body. One of the very important component of the professional welfare is the academic field. Knowledge enhancements comes out of research. The research will give us a lot of values and a lot of inputs to how to go ahead with that. I always firmly believe, as a leader in Indian Medical Association, whenever a knowledge or a concept is given to a doctor, it is not going to just benefit the doctor. It is not going to just to be within the doctor. It is definitely going to percolate into the community to the people whoever coming to contact with the doctor. So ultimate beneficiary of any research, ultimate beneficiary of any knowledge enhancement is not the doctor but the public. So having that in the mind, having that in the view that the community oriented medicine is going to help, research is going to help us, and Indian Medical Association now takes the pledge to promote the research on the various new aspects, preventive aspects, especially on the genetic disease. We see nearly 10 to 15% of the carcinoma breast is coming through the genetic features, and how best we'll be able to do the genetic counseling, how best we'll be able to do the people to come out of this. And especially when the people come, we still see in the villages, people come in the 4th stage, metastatic disease. And at that stage, what any other alternative ways are available. So all these research oriented people are there. Indian Medical Association is now setting up a separate body in which we have a research protocol development, and we are also establishing corporate fund for helping the people to do the research, and with the intention that we will be able to reach out. So I thank this opportunity where I will be able to say the priority will be on the prevention, on promoting the self-examination, and also availing the people, the next generation people, to subject their relatives and their wife, their people to the mammography examination, and also on the lifestyle modifications, which will be on the preventive side, and appropriate treatment protocol and the research modalities to further enhancement will be the mission being health part, in which the breast cancer control is one of the major part. Indian Medical Association will be taking care, and I will be sparing much time on this issue in this whole year. I am sure that with all your support, all the encouragements of a lot of academicians who are getting associated with Indian Medical Association, we will be able to do some justice in our objective of bringing down the highest mortality and highest incidence of breast cancer in our country. So thank you very much for your patient hearing, and thanks a lot.
Thank you, sir, for your elaborate spelling out your vision and the mission you are going to adopt for the prevention of breast cancer. You have spelled out the mission Pink Health in such detail. We are overwhelmed by your protocols. The protocol quality enhancement of hospital, ensuring every sector from PHC to other hospital to have quality protocol-based therapy to give uniformity for management of breast cancer, community orientation and patient-friendly approach, knowledge enhancement, research orientation, genetic basis, and corporate funds. You have touched from the beginning to end of everything about breast cancer. We are so thankful for the way you have spelled out your mission, sir. We are very grateful.
Shanta madam, mute la irkeenga madam.
The next one is
sir. Thank you for laying out.
Thank you very much, Jailal sir.
Thank you, madam.
The next one is issues in educating young girls on breast cancer awareness by Sister Annie Asha Ann.
Will you say a few words about her, Shanta?
Yes.
This is going to be
I don't know. I'll ask
the teacher who is going to speak to us. So Sister Annie has allotted one of the teachers of the St. Mary's school from Arambakam. Indumati teacher, are you with us?
Yes, sir.
Indumati teacher, நீங்க பேசலாம் டீச்சர். அறிமுகப்படுத்திக்கங்க, பேசுங்க. உங்களோட அனுபவங்களை பத்தி சொல்லுங்க டீச்சர். ஸ்கூல்லே இருக்கீங்கன்னு நினைக்கிறேன்.
ஆமா சார்.
நீங்க சாந்தினின்னு போட்டிருக்கீங்க. நீங்க ப்ரொசீட் பண்ணுங்க டீச்சர். பேசுங்க. தயவு செஞ்சு பேசுங்க.
ஓகே சார்.
வெல்கம் டீச்சர்.
வெல்கம் மேம். மேம் தமிழ்ல பேசலாம்ல மேம்?
ஆமாங்க, அப்பதான் நல்லா பேசலாம். தாராளமா.
நன்றி மேம். மார்பக புற்றுநோய் பற்றிய விழிப்புணர்விற்காக கருத்தரங்கில் கூடியுள்ள அனைத்து மருத்துவ பெருமக்களுக்கும் எனது மதிய வணக்கத்தை தெரிவித்துக் கொள்கிறேன். இந்நோய் பற்றி முதலில் நான் அறிந்து கொள்வதற்கு ஒரு நல்லதொரு வாய்ப்பை ஏற்படுத்தி கொடுத்த திரு டாக்டர் கனகவேல் அவர்களுக்கும் எமது பள்ளி தலைமை ஆசிரியர் அவர்களுக்கும் எனது நன்றியை தெரிவித்துக் கொள்கிறேன். புற்றுநோயை உண்டாக்கும் செல்கள் அங்கொன்றும் இங்கொன்றுமாக நமது உடலில் எப்பொழுதுமே இருந்தாலும் அதன் தாக்கம் தற்போதுதான் அதிக அளவில் பரவி வருவதை நாம் கண்கூடாக காண்கிறோம்.
ஆயினும் அது குறித்த விழிப்புணர்வோ முன்னெச்சரிக்கை நடவடிக்கையோ பள்ளி கல்லூரியில் படிக்கும் நம் மாணவிகளுக்கும் இளைய தலைமுறையினருக்கும் இல்லை என்பது வருந்தத்தக்க விஷயமாகும். ஒவ்வொரு 2 நிமிடங்களுக்கும் ஒரு பெண் மார்பக புற்றுநோயால் கண்டறியப்படுகின்றார். ஒவ்வொரு 13 நிமிடத்திற்கும் ஒரு பெண் இந்நோயால் பாதிக்கப்பட்டு இறக்கிறார் என ஒரு கருத்து கணிப்பு கூறுகிறது. இந்தியா, சைனா, அமெரிக்கா போன்ற நாடுகளில் பல்வேறு பெண்கள் இதன் மூலமாக பாதிக்கப்பட்டு இருந்தாலும் மற்ற நாடுகளில் 8 1 பெண்ணிற்குத்தான் இந்த அறிகுறி காணப்படுகிறது. ஆனால் இந்தியாவில் பாதிக்கும் மேற்பட்ட பெண்கள் இந்த அறிகுறியால் பாதிக்கப்படுகின்றனர். ஆனால் இதனுடைய தீவிரத்தை மாணவிகள் எந்த அளவிற்கு புரிந்து கொண்டிருக்கின்றனர் என்று தெரியவில்லை. எனவேதான் நமது அரசு ஒவ்வொரு வருடமும் அக்டோபர் மாதத்தினை மார்பக புற்றுநோய் விழிப்புணர்வு மாதமாக அறிவித்துள்ளது. அரசும் சுகாதாரத்துறையும் மருத்துவர்களும் எவ்வளவு முயற்சிகளை மேற்கொண்டாலும் நம் நாட்டு பெண்களிடம் காணப்படும் கூச்சம், தயக்கம் மற்றும் தவறான சிந்தனைகளால் இதை பற்றி வெளியே பேசவோ பரிசோதனை செய்து கொள்ளவோ ஆர்வம் காட்டுவதில்லை. எனவே மாணவிகளுக்கு நாம் இதன் தாக்கம், சுய பரிசோதனையினுடைய முக்கியத்துவத்தை கற்றுக் கொடுப்பது மிகவும் அவசியமாகிறது. இதனை எவ்வாறு செய்யலாம் என்றால், மாதவிடாய் முடிந்து 7 நாள் கழித்துத்தான் இந்த பரிசோதனையை செய்ய வேண்டும். ஒவ்வொரு மாதமும் குறிப்பிட்ட நாளினை தேர்வு செய்து அந்த நாளில் மட்டுமே செய்ய வேண்டும். மாதவிடாய் நாட்களில் இதனை செய்யக்கூடாது. ஏனெனில் அப்போது மார்பில் வலி, நீர் கோர்த்தல் போன்றவை சிலருக்கு இயல்பாகவே இருக்கும். எனவே அந்த நாட்களில் சுய பரிசோதனை செய்தல் வேண்டாம். பெண்கள் முதலில் கவனிக்க வேண்டியது என்னவெனில், திடீரென்று மார்பகங்கள் பெரிதானாலோ, நிறம் மாறி இருந்தாலோ, மார்பு மேல் தோல் சுருங்கி இருந்தாலோ, மார்பில் குழியாக தோன்றினாலோ, முளைக்காம்புகள் உள்நோக்கி இழுக்கப்பட்டு இருந்தாலோ, புண், வலி, கட்டி போன்றவை உள்ளதா என்பதனை பரிசோதனை செய்து கொள்ளல் வேண்டும். அதற்கு முதலில் இடுப்பில் கைகளை வைத்து கண்ணாடி முன் நின்று நமது மார்பினை கூர்ந்து கவனிக்க வேண்டும். பின்னர் கைகளை தலைக்கு மேல் உயர்த்தி கையின் அடிப்பகுதி, மார்பினை சுற்றி ஏதேனும் வித்தியாசம் உள்ளதா என சோதிக்க வேண்டும். பின்னர் மார்பில் 3 விரல்களை வைத்து கடிகாரம் சுழற்றும் திசைக்கேற்ப அழுத்தி பரிசோதிக்கலாம். ஏதேனும் அறிகுறி தென்பட்டால் முதலில் தமது குடும்ப உறுப்பினர்களிடமோ மருத்துவர்களிடமோ தங்களது சந்தேகங்களை கேட்டு தெரிந்து கொள்ளல் வேண்டும். இவை பொதுவான அறிகுறிகளாக தெரிந்தாலும் இதனை எளிதில் குணப்படுத்த முடியும். முன்பெல்லாம் புற்றுநோய் என்றாலே இறந்து விடுவர் என்ற நிலை தற்போது முற்றிலுமாக மாறியுள்ளது. தற்போது மெமோகிராம், MRI, அல்ட்ராசவுண்ட், பயாப்சி போன்ற அறிக்கையின் மூலம் துல்லியமாக அதனை கணிக்க இயலும். ஒருவேளை பாதிக்கப்பட்டால் பாதிக்கப்பட்டவரினுடைய வயது, நோயின் தன்மை, குடும்ப வரலாறு, நோயின் வேகம் மூலம் எளிதில் சிகிச்சையினை அளிக்க முடியும். மேலும் அறுவை சிகிச்சை, ரேடியேஷன், கீமோதெரபி, ஹார்மோன் சிகிச்சை, டார்கெட்டட் தெரப்பி போன்ற சிகிச்சைகள் மூலம் முற்றிலும் இதனை தடுக்கவும் குணப்படுத்தவும் முடியும். இந்த நோயின் அறிகுறிகளை கவனிக்காமல் தவறினால் விளைவுகள் மிகவும் மோசமாக இருக்கும். எனவே இதனை வரும் முன்னரே தடுப்பது மிகவும் அவசியம். இதற்கான காரணங்களாக கண்டறியப்படுவை யாதெனில், முன்பெல்லாம் பருவமடையும் வயது 14 to 15 வயதிற்குள்ளாக இருந்தது. தற்போது 8, 9 வயதிலேயே பெண்கள் பூப்பெய்து விடுகின்றனர். மேலும் 50 முதல் 55 வயது வரை மென்சஸ் என்பது நிற்பதே இல்லை. இவை அனைத்திற்கும் காரணம் ஈஸ்ட்ரோஜன் எனக்கூடிய ஹார்மோன் மட்டுமே. கருப்பை நீக்கியவர்கள், உடல் பருமன், புகை, மதுபானம், காலம் தாழ்த்தி குழந்தை பெறுதல், குழந்தையின்மை, தாமதமாக 35 வயதில் நடக்கும் திருமணம், கொழுப்பு நிறைந்த உணவுகள், பரம்பரை நோய், குடும்ப வரலாறு, சொந்தத்திற்குள் திருமணம், குழந்தைக்கு சரியாக தாய்ப்பால் கொடுக்காமல் இருத்தல், நீண்ட காலமாக கருத்தடை மாத்திரைகளை உபயோகித்தல், உடற்பயிற்சி செய்யாதிருத்தல், அதிகப்படியான உணவு உட்கொள்ளுதல் போன்றவைகள்லாம் ஒரு காரணமாக அமையும் என கூறுகின்றனர். இதைவிட முக்கியமான காரணம் ஒன்று உண்டெனில் அது மன உளைச்சல். மன உளைச்சல் இருப்பதனால் புற்றுநோய் உருவாக்கும் செல்கள் இவற்றை தாண்டி மிக வேகமாக வளர்ச்சி அடைகின்றது. 50 வயதுக்கு மேற்பட்ட பெண்களை பாதித்து வந்த ஒரு மார்பக புற்றுநோய் தற்போது 30 வயது கொண்ட பெண்களைத்தான் அதிகமாக தாக்குவதாக கண்டறியப்பட்டுள்ளது. ஆனால் ஆண்களும் மார்பக புற்றுநோய்க்கு ஏற்படும் என கண்டறிந்துள்ளனர். இவர்களுக்கு பொதுவாக புகைப்பிடிப்பதாலோ 15% மார்பக புற்றுநோய் ஏற்படுகிறது. பரம்பரை நோயின் மூலமாக கூட இவை பரவுகிறது. மரபு வழியில் வரும் இந்த புற்றுநோயை சரியான நேரத்தில் கண்டறிந்தால் சரி செய்து விடலாம். மேலும் தினமும் சூரிய ஒளி உடல் மேல் பட்டாலே மார்பக புற்றுநோய் வராது என கனடா நாட்டு ஆராய்ச்சியாளர்கள் கண்டுபிடித்துள்ளனர். சூரிய ஒளி உடலில் படும்போது விட்டமின் D உற்பத்தி தூண்டப்பட்டு
இவை ஒருவித ஹார்மோனாக மாறி மார்பகத்தில் புற்றுநோய் வராமல் தடுக்கும் என கூறுகின்றனர். சுய பரிசோதனை செய்யும் போது நாம் சரியாக செய்கிறோமா என்ற சந்தேகம் அனைவருக்கும் எழும். ஆனால் இதை தொடர்ந்து மாதந்தோறும் செய்வதன் மூலம் ஏதேனும் மாற்ற மார்பகங்களில் இருந்தால் விரைவில் கண்டறிந்து விடலாம். 40 வயதை கடக்கும் அனைத்து பெண்களும் 3 வருடத்திற்கு ஒருமுறை தவறாமல் மருத்துவ பரிசோதனை செய்து கொள்வது அவசியம். தற்போது அனைத்து ஆரம்ப சுகாதார நிலையங்களிலும் அரசு மருத்துவமனைகளிலும் இதனை இலவசமாகவே செய்து விடுகின்றனர். எனவே மாணவிகள் சத்தான பழங்கள், காய்கறிகள், உணவுகள் உட்கொள்வதன் மூலமும் யோகா பயிற்சி, நடைப்பயிற்சி போன்றவை செய்வதன் மூலமும் ஆரோக்கியமான வாழ்க்கையை வாழ முடியும். இவை தவிர இந்நோய் பற்றிய விழிப்புணர்வு பெண்களுக்கு ஏற்படுத்துவதன் மூலம் இந்நோயிலிருந்து விடுபடலாம். மாணவிகள் இதனை தெரிந்து கொள்வதோடு தம்மை சுற்றியுள்ள அனைத்து பெண்களுக்கும் கொண்டு சேர்ப்பதன் மூலமும் மார்பக புற்றுநோயற்ற சமுதாயத்தை உருவாக்க முடியும் என நான் நம்புகிறேன். எனவே கூச்சத்தை தவிர்ப்போம், புற்றுநோயற்ற சமுதாயத்தை உருவாக்குவோம் என வாய்ப்புக்கு நன்றி கூறுகிறேன். விடைபெறுகிறேன். நன்றி.
டீச்சர் ரொம்ப நன்றி. நீங்க வந்து உங்களோட வியூவை வந்து ஷேர் பண்ணிக்கிறதுக்கு ஐஎம்ஏ சென்னை சவுத் சார்பாக ஐஎம்ஏ இந்தியன் மருத்துவக் கழக சென்னை தெற்கு கிளையின் சார்பாக உங்களுக்கு எங்களோட நன்றியை தெரிவிச்சுக்கிறோம். மேடம், லாஸ்ட் இயர் வந்து இந்த ஸ்கூல் பிள்ளைங்க வந்து ஒரு பெரிய கேன்சர் அவேர்னஸ் ப்ரோக்ராம் பண்ணாங்க. There were more than 200 children we participated. We also helped them to educate the girl children regarding adolescent and menstrual health in that school. So let us have one program once this pandemic situation clears. The sisters and the school teachers are very friendly and are very happy to contribute to us.
Thank you.
Thank you, teacher. And உங்க அந்த ஸ்டூடெண்ட் இப்ப பேசுவாங்களா டீச்சர்?
பேசுவாங்க சார். ரெடியா சொல்லுங்க. ஓகே
டீச்சர், ரொம்ப அழகா கூச்சத்தை தவிர்த்து செல்ஃப் எக்ஸாமினேஷன் போகணும்னு சொன்னது ரொம்ப ரொம்ப அழகான மெசேஜ். ரொம்ப தேங்க்யூங்க.
தேங்க்யூ மேடம்.
இந்த ஸ்கூல் பிள்ளைங்க வந்து ஒரு பெரிய ஒரு வரப்பிரசாதம் சொல்லணும். என்னன்னா அவங்க வந்து they are individually capable. ஒரு ட்ரிகர் கொடுத்த உடனே they were able to create such a brilliant program. They started educating the community. So we have a wonderful had an experience with them, and I thank the students, the teachers, and the principal for committing them to this important cancer awareness. Now we call upon Miss Saranya, a student from 12th standard from this school which is in a rural area, to contribute what is their vision in educating the community. Saranya ma பேசுங்க.
நிகழ்ச்சி பங்கேற்றுள்ள அனைத்து மருத்துவர்களுக்கும் எனது பணிவான மாலை வணக்கம். சுய கற்றல் ஓர் ஆசிரியர் அல்லது பயிற்றுனர் உதவியின்றி தானே கற்பது சுய கற்றலாகும். அதாவது தானே தகவல்களை சேகரித்து பிறர் உதவியின்றி கற்பது சுய கற்றலாகும். வகுப்பறை ஆசிரியரின் துணை உதவியின்றி தகவல்களை சேகரித்து புரிந்து கொண்டு மனதில் இருத்தி வைத்தலே சுய கற்றலாகும். சுய கற்றலின் முக்கியத்துவம்: எவ்வாறு கற்பது என்பதை புரிந்து கொள்ளல். வாழ்நாள் முழுவதும் கற்பதற்கு சுய கற்றல் தேவைப்படுகிறது. வாழ்க்கையில் அனைத்து அம்சங்கள் பற்றி தெரிந்து கொள்ள சுய கற்றல் தேவைப்படுகிறது. அனைத்தையும் பற்றி கற்பதற்கு வெளிப்புற சாதனங்களோ பிறர் உதவியோ எப்போது கிடைக்கும் என்று உறுதியாக சொல்வதற்கில்லை. சுய கற்றல் மூலமே இது சாத்தியமாகிறது. சுய கற்றலின் நன்மைகள்: சுயமாக சிந்திக்கும் ஆற்றல் உடையோராக மாறிவிடுகின்றனர். பொறுப்பேற்க கற்றுக்கொள்கின்றனர். தடையின்றி கற்கும் சுதந்திரத்தை பெறுகின்றனர். சுய முயற்சியால் பிரச்சனைகளுக்கு தீர்வு காண பழக்கப்பட்டிருப்பதால் அதிக தன்னம்பிக்கையுடன் விளங்கி எந்த ஒரு சோதனையும் வென்றிடுவார். பெற்றோர்கள் ஆசிரியர்களிடமிருந்து தகவல்களை பெற்று கற்றிடுவோரை காட்டிலும் சுய கற்றலில் ஈடுபடுவோர் கற்றவற்றை அதிக காலம் நினைவில் வைத்திருக்க முடிகிறது. எங்கு உதவி தேவைப்படும் போது எங்கு நாடி செல்ல வேண்டும் என்பதையும் கற்றுக்கொள்வர். சுய கற்றல் மூலம் பள்ளி மாணவர்கள் கல்லூரி படிப்புக்கு தேவையான சுய ஊக்கத்தினையும் முன்கூட்டியே திட்டமிடும் ஆற்றலையும் பெறுகின்றனர். சுய கற்றல் மாணவர்களிடம் சிறந்த பணி ஒழுக்கத்தை வளர்க்கிறது. மாணவர்கள் பாடப்பொருளை எந்த அளவு ஆழமாக கற்க வேண்டும், எந்த அளவு பாடப்பொருளோடு இடைவினை ஆற்றிட வேண்டும் என்பதை குறித்து என்பதை குறித்த சுதந்திரத்தை மாணவர்களுக்கு சுய கற்றல் அளிக்கிறது. சமுதாய கல்வி. சமுதாயம் என்பது ஒருவரது இல்லத்தை சுற்றி அமைந்திருக்கும் பெருநகரங்களில் வாழ்வோரையும் அப்பகுதிக்கு அடிக்கடி வந்து செல்வோரையும் குறிக்கிறது. சமுதாயம் குழந்தையை சமூகவியல் பாக்குதலில் குடும்பம், பள்ளி போன்று நேரடியாக பங்கு கொள்வதில்லை. அது சமுதாய வாழ்க்கை என்னும் ஊடகத்தின் மூலம் குழந்தையை மறைமுகமாக சமூக நெறிப்படுத்துகிறது. தனது தனித்தன்மை வாய்ந்த கலாச்சார பாரம்பரியத்தை குழந்தைக்கு சமுதாயம் அளிக்கிறது. பள்ளி, செய்தி தொடர்பு ஊடகங்கள், தொழிற்கூடங்கள், பயிற்சி நிலையங்கள், நூலகங்கள், ஆய்வு கூடங்கள், பொது நிகழ்ச்சி அரங்குகள் போன்றவை சமுதாயத்தால் படைக்கப்பட்டு நெறிமுறைப்படுத்தப்பட்டவையே ஆகும். விளையாட்டு, நுண்கலை, கலைத்திறன் போன்றவற்றில் பல்வகை போட்டிகளை நடைபெற செய்து மக்களிடம் ஜனநாயக நெறிமுறைகளையும் வளர்க்கிறது. பத்திரிகைகள், வானொலி, தொலைக்காட்சி போன்ற பொதுமக்கள் செய்தி பரப்பு சாதனங்கள் பெருவாரியான மக்களின் கருத்துக்களையும் பிற தகவல்களையும் அளிப்பதன் மூலம் குழந்தைகளது சிந்தனையிலும் கண்ணோட்டங்களிலும் மாற்றங்கள் ஏற்பட துணை புரிகின்றன. சமூக பயனுள்ள ஆக்க செயல்களில் மாணவர்களுக்கு பயிற்சி அளித்தலின் குறிக்கோள்கள். சமுதாயத்தில் நடைபெறும் உற்பத்தி தொழில்கள் பற்றி மாணவர்கள் தெரிந்து கொள்வதோடு உடல் உழைப்பில் ஈடுபடுவோரை மதிக்கும் மனப்பான்மையும் வளர்த்தல். சமுதாய பிரச்சனைகளை பற்றி மாணவர்கள் தெரிந்து கொள்வதுடன் சமுதாய சேவை செய்வது குறித்து சரியான மனப்பான்மையை வளர்த்தல். சமுதாயத்தில் பயனுள்ள உறுப்பினர்களாக வாழவும் சமுதாய முன்னேற்றத்திற்கு தங்களான பங்கினை ஆற்றவும் விருப்பத்தை வளர்த்தல். தன்னம்பிக்கை, உடல் உழைப்பின் மேன்மை, சகிப்புத்தன்மை, கூட்டுறவு, பிரிவு, பிறருக்கு உதவுதல் போன்ற பண்புகளை வளர்த்துக் கொள்வதோடு வேலை செய்யும் மனப்பான்மையும் வளர்த்தல். பல்வேறு தொழில் அல்லது வேலை செய்வதன் நுணுக்கங்களை அறிதல். படிப்படியாக செய்யும் தொழில் மூலம் திறமையை வளர்த்துக் கொள்வதோடு படிக்கும் போது செய்யும் திறமை மூலம் பொருளீட்டும் திறமையை வளர்த்தல். படைப்பாற்றலையும் சிந்திக்கும் ஆற்றலையும் வளர்த்தல். இத்தகைய பண்புகளை மாணவர்கள் சமுதாய கல்வி மூலம் பெறுகின்றனர். நன்றி.
தேங்க்யூப்பா.
சரண்யா, ரொம்ப நல்லா பண்ணீங்கம்மா. ரொம்ப சந்தோஷம். ஒரு ஷார்ட் டைம்ல ஒரு டாக்டர்கள் பேசுறதை விட நீங்க தெளிவான மெசேஜ் கொடுத்துருக்கீங்க. நீங்க எவ்வளோ உங்களோட ஈடுபாடு இருக்கு, உங்களோட கான்ட்ரிபியூஷன் உங்க சொசைட்டிக்கு இருக்குன்றது வந்து எங்களுக்கு நல்லா தெரிஞ்சது. தேங்க்யூ ஸோ மச். நீங்க நல்ல பெரிய சமூகத்துல ஒரு முக்கியமான பங்கு ஆற்றுறதுக்கு எங்களோட வாழ்த்துக்களை தெரிவிச்சுக்கிறோம் இந்திய மருத்துவ கழகம் சார்பாக. சாந்தா மேடம், நீங்க பிரசிடென்ட் சார் ரெண்டு பேருமே வாழ்த்துறீங்கன்னா அந்த குழந்தைக்கு ரொம்ப
பிரசிடென்ட் சார்
தெரியல. இவ்வளவு படிச்சுட்டு வந்து இவ்வளவு அழகா சொல்லியிருக்காள் பொண்ணு. நிச்சயமா பெரிய ஆளாதான் வருவான்னு நினைக்கிறேன். வாழ்த்துக்கள்மா.
வாழ்த்துக்கள்மா.
சரண்யா, சுய கற்றல் பற்றி இவ்வளவு அழகா பேசிருக்க. எங்க யாராலையுமே இது மாதிரி பேச முடியாது. ரொம்ப ரொம்ப கிரேட் மணி.
Thank you. Thank you. Next we will have How I Won Breast Cancer by Ramamani.
Thank you Saranya madam. Thank you Indumati teacher. Thank you for joining us today.
Thank you.
நீங்க நாங்க பேசுறத கவனிக்கலாம், என்ன பேசிக்கிறோம்ன்றதை தொடர்ந்து கவனிக்கலாம். சரிங்களா? Madam, please proceed madam.
Yeah. Thank you madam. Now I call upon Mrs. Ramamani Ravi. Rama?
Yes.
Yeah.
Yeah, I am there.
Dr. Ram, one second. Next speaker, Mrs. Ramamani Ravi. One நிமிஷம். Shanta madam, Ramamani Ravi. Sorry. Dr. Mrs. Ramamani Ravi is mother of Niranjan Ravi, a person in the autism spectrum. Now he is 35 years old. He is a BCom graduate after marriage. She did her law in the university, first all 3 years with 3 gold medals. She went on and completed her CA. Recently, she did her BA Special Education from Tamil Nadu Open University. She stood first with a gold medal. She has been an integral part of a special school for over a decade. Continues to be the honorary treasurer of Muscular Dystrophy Association of India for the last 13 years. and now has started a center for adults with special needs. Over to you, Mrs. Ramamani.
Thank you.
Rama, your video, please.
I'm on. I am on.
Okay, just see.
Can you see me?
Yes, go ahead, Rama, go ahead.
Yeah. Yeah. Good evening to every one of you there, and my special pranams to my doctor, Dr. Shanta of Cancer Institute. My doctor. However, I consider boon to be associated with the Cancer Institute, with doctor and the entire team at the Cancer Institute. Let me put my story short. In 1997, I had a slight doubt as to whether a small thickening of the skin under my breast, it kept nagging in my mind, and Dr. Shanta was not in the country at that time. So I had been to a gynecologist who told me that everything is all right, but still my intuitive mind kept saying, no, something is not okay. This intuitive mind has been guiding me in my son's journey as well as in my journey all through. And so when doctor came back, I think the first day, along with my father, I went and I had to meet her 97 November, a day when it was raining just like how it was this morning. And doctor, with all her expertise and knowledge, she just touched and she had her doubts. She did an examination, and she asked me to come for an FNAC, and whatever followed after that, the treatment, that would be almost the same story which you can hear from any survivor. And so I'm not going into that part of it. But what actually made a difference is the strong words of Dr. Shanta, not once, but every time I had to meet her, which instilled so much of confidence and positive strength in me to face the treatment. Being a mother of Niranjan, who was just 13 years old at that point of time, I had a day with a lot of activities, and I still continue to have the same. Living two lives, every parent of a special needs child has to live two lives continuously. Her own life and that of her child. Day after her, I had one question I could tease with my son. Why I'm giving so much of importance to this is what she said gave me all the confidence to meet the treatment. She said, you can continue with what you've been doing. There was not much of net or books or anything available. Books, of course, yes, but not many survivors whom we could meet. Today, we have a lot of survivor meets, and even Dr. asks me to talk to some of the patients so that they get motivated. It was not like that then. This is way back 23 years ago. So in a way, it was good because I didn't have much information on the net to confuse me. But still, going to a radiation or a chemotherapy or whatever, there were many people saying so many things, don't do this, have this, don't have that, and whatnot. But all that doctor said was, you continue to do. If you have to take him for a class, you can take him. If you have to do this for him, you do. You don't have to change your lifestyle for this sake. You continue, come here on the dates when we ask you to come for radiation or chemotherapy. And so that was how I just surrendered, knowing fully that I was in safe hands, and the confidence that I had in doctor, not just with my treatment, but my mother also being a cancer survivor. She is now 83 years old. 44 years back, Dr. Shanta has done the same treatment for my mother. And as two daughters who were just 13 and 8 years old, we never ever knew that she had something big at that time. She has lived her life doing all her duties for her daughters, sons-in-law, their families, grandchildren, etc. And we have never ever seen her as a patient, and she also has been a very great source of motivation for me. And this I can say confidently, that a diagnosis of cancer is not as frightening as being a mother of a person with autism. It is a time specific where you go to the institute, say for 6 months, 8 months, whatever, there and given cooperate with them, and then it is the Principal Murray. I had a bigger line, that of autism, and so this seemed very small to me. And the Cancer Institute, everything that is needed was available. So I did not have to go here and there and all that. Just go there on those dates, and they ensure that they give you the treatment, and also the word that doctor used, quality life, that she is very particular. Quality, yes, because I keep asking her whether what she had put inside me when she did the surgery, that I'm stronger than before, that I'm healthier than before. Because I'm able to carry on not just with my son, with other families who have special needs, and also with the Muscular Dystrophy Association. And this quality life, I am sure it would not have been possible except for the encouragement and the hope that she gave me on day one. When the surgery was over and I had to leave home, and I asked her, "Doctor, when can I drive?" That was the time when I could not move my hand even 1 millimeter after the surgery. She told me, "You can drive home tomorrow." I never thought it's a joke. I took her very seriously, and within 6 months, believe it, I was driving, putting the reverse gear. It was a geared vehicle, and I started doing everything. So this is the power of positive words that come from a doctor. What are the medicines or the treatment that the doctor gives are secondary for a patient. I am talking from the patient point of view. The words of the doctor are the most important, and every year wait for my annual review to go there, which is my second, have the same amount of vibration of positivity there, and they boost our levels of confidence and strength. The hope and the positivity that is radiated again and again, I say, that are more important, so that the treatment is effective for the patient. The patient becomes very scared, just like how we see for corona, even a small cold or a fever, and somebody thinks they've got corona. That sort of fear starts getting into the, once you see the board cancer over there. And that is not the end, and it is not death. It is clearly the starting of a new life, which is going to be much, much better than before. And I strongly feel every experience that has come into my life, whether it is Niranjan or whether it is other families or cancer, it has taught me to be a better person, and it has given me rich experience and a better perspective of my life. And so the positivity is the only point that I keep saying, because unless and until we give that positive strength to a patient, we will not be able to reach out to him at all. And the amount of fear, what do you say, lack of confidence that we have because we take a doctor as a God. The words of the God, and believe God lives in human form, in the form of God. And in my life, Niranjan, I would definitely say as an issue, and we are able to go there, which no other country we can do. So positive words are the most important. I thank you for this opportunity. If there's anything else you want me to share, I'm happy to.
Thank you, Mrs. Ramamani, for a wonderful lecture on your the fight you had in your life. Fight against cancer, fight against autism, fight against muscular dystrophies, and so many more activities. It was a wonderful narration of your activity. We are spellbound. Thank you once again.
Yeah, the next topic is diagnosing imaging in breast cancer by Dr. Purnima.
Thank you.
Dr. Purnima?
Yeah, I'm there. I'm there, ma'am.
Is she online?
Yeah, I'm online. I'm online.
Dr. Purnima belongs, is the director of Athens Scan. She is an undergraduate from Salem. She did a DNB in radio diagnostics from Barnard Institute of Radiology, Madras Medical College. Her areas of interest are general radiology, women imaging, gastrointestinal radiology. She has worked as a consultant in precision diagnostics. She has established Athena Diagnostics. Over to you, ma'am.
Thank you, ma'am. Thank you. A very good afternoon to all of you over here. Thank you, Dr. Shanta ma'am, Shanta Narayanan ma'am, and Kanagavel sir for having me over here. I'm really humbled to be sharing the platform with doyens like Shanta ma'am from Cancer Institute. Most of you here on the screen are seniors to me, and you know me, and it's really humbling to be over here. So my part as a radiologist is here to talk about the diagnostic imaging in breast cancer. It's really overwhelming to see the way a teacher from a rural school and a student talking about the awareness of prevention of breast cancer, about self-examination, and to listen to Mrs. Ramamani about her fight with the cancer and getting over it. It's really overwhelming. So my part, each and every one of us, whether you are a surgeon or a clinician, obstetrician, or a general physician who sees a patient first, even as a radiologist, it is our part that we need to play in preventing and creating awareness about this disease. So the aim of the entire program is to find it, treat it, and cure it. We have come a long way in the treatment of cancer breast. As Shanta ma'am beautifully said, gone are those days when women used to present with large lumps or metastasis. Those days are gone, and now the target is to find them early, even before it is clinically evident. Find the lesion, treat it and cure it and get over it, so that you give a quality life to the person, whoever is affected by this. So this all of us know, she's Angelina Jolie. We need not be like her, where she went in for a genetic counseling. She found she has a mutation, and she went for bilateral mastectomy for a preventive mode. If not to her level, at least women should know that this thing is existent. We should be able to find out, and the purpose of this entire program is to create that awareness in women. So with breast cancer, information is your best weapon. So how do we fight it? This enough has been spoken about it right from the beginning when Yashoda ma'am started the entire program. She said breast cancer, of course, in India, it is becoming the #1 cancer in women in India. And this is the statistics that we have had in 2018, about 1,62,468 new cases were found out, and 87,090 deaths were reported in India. This is really alarming. And even more alarming is urban women are affected more, which Shanta ma'am beautifully reiterated. And then certain facts of breast cancer in India, you see the incidence increases with age, but we are seeing an age shift that is in the recent past, with more and more younger women getting affected. In India, about 48% of all breast cancer cases happen below the age of 50. And in younger women, breast cancer is more aggressive and has a poorer prognosis. That's why all this awareness creation is of utmost importance. So this makes all the women at risk. Gone are those days when they say old women are at risk. Now all of us are at risk. And small statistics in Chennai, the percentage of cancer among women is about 26.8%. So early detection is the key. Early detection saves lives. That's why we need to find out before even it is clinically seen, or when it is just localized to the breast, when it is as small as a peanut, it's when we need to find it out. So what are the ways? Beautifully, enough has been spoken about breast examination. Any girl beyond 20 years of age needs to do it every month. And if if they are menstruating after 7 days of menses and not menstruating, fix a date every month. This is a small video about how, see, we all speak, but visual memory creates an impact. So that's it. We can make use of such small videos to talk to people when we are talking for the mass gathering, because visual memory always remains in certain people's brain better way. And as radiologists, whenever we have young girls coming for routine ultrasound of the breast, or if they have seen a lump, they come, we make it a point. Ours is a team of lady radiologists. So we make it a point to teach them how to do the self-examination. The general mistake that the girls do is they hold the breast tissue between their thumb and the rest of the fingers, thereby even a normal breast feels lumpy. So we teach them how to use their palm or just the 4 fingers to do the self-examination. So that bit is what we contribute towards creating awareness. And then if you find a lesion, then getting the clinical breast examination becomes mandatory, or if not, once in 3 years is what we recommend for any regular examination. And next, moving on to the radiology part of it, X-ray mammography is the only screening modality available right now, for detection, though there are advances like MRI and other things that has come. But in a country like India, X-ray mammography is the available and most sought after screening modality that is sought after. I'll tell you what are the reasons why we don't prefer other modalities. So what is the definition of screening for breast cancer? Can be defined as the evaluation of women who have no overt signs or symptoms in an effort to detect unsuspected disease at a time when cure is still possible. We are still there. As we all spoke, our country is still not there. We are there at least to detect the lesions when they are localized. So mammographic screening is the first step in the total management of the woman with breast cancer. This goal can only be attained through rigorous, high quality screening, diagnosis, and treatment. So screening, apart from finding out the disease at an early stage, it also can act as a filter. It sifts those who have abnormalities for further evaluation. We know if there is an abnormality, is it a benign condition or a malignant condition, and how we can triage these patients. The screening helps for that also. So coming to screening, who should be screening? What age they should be screened? When should they be screened? And how often should they be screening? There are various different schools of thoughts that go around about this screening. So before we look into the screening aspect, what are the risk factors? Enough has been spoken about the risk factors. So depending upon the risk factors, the screening can be modified for can be tailor-made for the individuals. So it is the sex and age, we know it is more common in the female patients. Age, we spoke about it. Older age, nowadays even the younger women are more prone for it. And in a person who has had early menarche and who has late menopause, these are also people who carry high risk for breast cancer. Nulliparous, or the late first pregnancy, and affected first degree relative, mom, sister, or
early menarche, late first pregnancy.
Can I proceed, please? Yeah.
Yes.
And a person who is on hormone replacement therapy, or if they are prone for gene mutation, or alcoholism and smoking, obesity and sedentary lifestyle, these are all the risk factors. So what are the screening methods? As I said, it's X-ray mammography, but when it is combined with ultrasound, it gives better results. So the guidelines for screening mammography is, according to various organizations, they say it should be 40 to 49. It is about every 2 years is one school of thought, or some people say it is annual. So we can choose if somebody does not come under the high risk category, they can choose to come once in 2 years. And if somebody has any of the risk factors that we discussed, they need to undergo an annual screening. And anybody 50 and above, annual screening is recommended by most of the organization, though they don't stipulate any upper age limit. Is being
Please. Hello, mute yourself. Hello.
Ma'am, can I just proceed?
Wait a one second, ma. Somebody is talking. Hello.
Yeah.
Hello. Please mute, all of you mute your mics, please. Just continue, ma.
Thank you, ma'am. Thank you. So screening mammography, the guidelines, somebody who is with high risk group needs to have an annual screening between the age group of 40 and 49. And anybody does not fall in the high risk group, they can have a screening for once in 2 years. And anybody beyond 40 years who comes for the first visit, even for a thickening of skin or anything, totally not even high risk, and if they have not had any mammograph till then mammography is mandatory in this age group. Just an ultrasound breast is not at all recommended. It's unless the person has had a mammography some 6 months before, or say 3 months before, then a mammo is not indicated. But if the person has never had a mammography, and if it is more than a year that she has had a mammogram and she comes with even a slightest of the symptoms, then mammography is mandatory, and ultrasound is not the modality of choice for women in this age group. And 50 and above, annual screening is recommended by most of the organizations world over, and India also. This is the routine that we follow. So when should we do? I have already spoken. So women in their 40s, we have spoken about this. And some people may need mammograms before the age of 40 also. I said now, as we discussed, the 30s, we have seen patients in their 20s, late 20s coming with CA breast. We are even alarmed to write the report, so that is the scenario right now. In that case, we should not hesitate to do a mammogram even in an younger age group. And if there is a family history, strong family history, we can always recommend them to go for a genetic testing, or if need be, if there is something we feel it is an occult lesion which cannot be picked up by an MRI, then we can even ask for an MRI. So there are any investigatory modality, any diagnostic modality, it has its own pros and it has its own the other side, the flip side. So what are the pros of mammography? It finds cancer at an earlier stage, as we said, prior to when they would be detectable with palpation. It allows even smaller cancers are picked up in mammography. Thus, the prognosis for a small tumor is better before they metastasize, even to the lymph nodes in the axilla. Before the metastasis is there, they can be picked up. Smaller cancers are amenable to breast conservation. So when the breasts are conserved, it's a better cosmetic outcome, and it has a better psychological effect on the women. Some women, now the awareness is better, they don't hesitate, but some women have some psychological impact which can be avoided if the breasts are conserved. And there is no other technology that has been shown to systematically find tumors at an earlier stage. Another advantage of mammography is picking up of microcalcifications. Because we use soft X-rays to image the breast, the microcalcifications can be seen only in a mammography. It cannot be picked up in ultrasound. That's why we recommend mammography in any woman beyond 40 if there is any suspicion. Ultrasound should not be done, because there is less likely a chance of picking of microcalcifications in ultrasound. And what is the flip side of mammography? Can it pick up all the cancers? No, not. The sensitivity is only 83 to 97% depending upon age. Why this happens is in younger women, when the breasts are dense, the glandular nature, it's densely glandular, we are likely to miss lesions in mammography. And dedicated interpretation team is required. As Shanta ma'am was telling, you need expertise to find out the interpret mammography. So that might not be available at all centers, but now it is more available, and people are more amenable to these facilities. And the anxiety component, women, it is, one person going and telling the other person, never get it done, it is very painful. And that is a wrong thing, Mammography, if done in the right hands, I mean, when the technician is well trained, what we call in our clinic is verbal anesthesia. When the person is more concerned, more talking to the person, set them at ease. And when you do the mammography, it is a very, very simple procedure. And it's, after all, a few seconds of compression is what is done to the breast tissue, and any woman can bear it. They have gone through better pain than this. We all know about the composition of breast. So these components of the breast is what is getting reflected in the mammograph films that we take. This is again a small video of how a mammography is done. So let us have a look at it.
A mammogram procedure uses low-dose X-rays to view and detect changes in breast tissue. A woman's breasts are composed of glandular tissue and ducts, fat, connective tissue, and blood vessels. If you detect a change in your breast tissue, such as a lump or mass, or if you are at least 40 years old, your doctor may schedule you for a mammogram. Before your mammogram, make sure that your breasts and underarms are clean and do not wear deodorant, since it may appear on mammogram X-rays as calcium spots. A mammogram usually takes about 20 minutes. A technician will begin by placing one of your breasts between two specialized plates. The plates will compress to flatten your breast so that the camera can get clear pictures of your breast tissue. You may feel some discomfort during the compression, but it will only last a few seconds. This procedure will then be repeated on your other breast. After your procedure, you may be asked to wait until a radiologist reviews your X-rays so that more pictures may be taken from different angles if necessary. Since a mammogram is a simple outpatient procedure, you will be able to go home immediately following the test.
Once the mammogram is done, we categorize the density of the breast depending upon the age group and how they're seen. Either they are diffusely dense or the fibroglandular density is there. You have fatty and fibroglandular, and some age-related changes like vascular calcifications. All these things can be seen. So these are some of the images that we see. This is completely fatty. This is fatty and fibroglandular. This is dense breast. This is extremely dense breast, D, where you can miss out on lesions. This is where mammography needs another modality to supplement the findings. And what do we see in mammogram? This is a normal mammogram. Usually two views are taken, a CC and an MLO view. And this is a normal mammogram where you see just ducts and the fatty density. This is a well-defined lesion that we see. This could be a benign lesion. And then you see this lesion, which is not clearly, it's not definitely well-defined. It is ill-defined, and certain characteristics that we will see. This is dense glandular breast where you can miss out on the lesion. In extremely fatty density, picking up the lesions is very easy. You see the lesion stands out like this, where you can see speculated margins of the lesion. And for sure, you know, this is a malignant lesion. This really does not need another imaging modality to confirm it. Whereas in this breast, where you see you're not sure whether there is a lesion or there's not a lesion, that's when the role of the next modality comes into. Tomosynthesis is a recent development in mammography, where, like how you see the slices of the breasts over here, the breast is imaged in thin slices. It's also known as three-dimensional imaging of the breast, wherein in extreme glandular density, when you do tomosynthesis, the breast can be seen in slices, and you have the facility to separate the lesion from the normal breast and bring out. So nowadays, in certain places, in advanced centers, tomosynthesis is being used as a screening modality instead of the regular 2D mammography. And these are some of the pictures of malignant lesions that you can see in mammogram. Though this is a well circumscribed lesion, it is ill-defined. This lesion looks obscured. This also is partly indistinct. You see the microlobulations, speculated margins, all these things should raise our antenna to look for it in a better way and go for another extra modality of investigation. These are certain microcalcifications, which I said can be seen only in mammograms and cannot be picked up in ultrasound. Then the reporting is done according to the BIRATS classification. If it is 0, we need the previous reports, or you have to recall for additional imaging. And the negative is 1, or benign. 3 is probably benign, 4 is suspicious. These are the categories which need further evaluation, 3 and 4. And 5, for sure, you know, it is highly suspicious of, it is suggestive of malignancy, so it needs a tissue diagnosis. Even 3 and 4 would need tissue diagnosis in many places, or if it is probably benign, you can call them up for a short interval follow-up. 6 is already known biopsy proven case. Certain myths of mammogram that the common people have is mammograms are painful, as I said. They really are not. If done very well, it is not at all painful. Number 2, I don't have any symptoms of breast cancer or a family history, so I don't need to worry about having an annual mammogram. This is the second myth. This is the fear which is holding them back, or it is a lack of awareness that holds the woman from getting a mammogram. A mammogram will expose me to an unsafe level of radiation. The radiation that comes out of a mammographic investigation is negligible. It is negligible. Probably we get more radiation by going out in the sun than getting a mammogram done. And breast self-exams are just as effective as mammograms? Definitely not. If there is, it's only to see that if you have any changes. If you see any changes, then the lesion is already there. Then the purpose of screening is not there. And myth 5 is, if I have any type of cancer in my breast tissue, screening mammogram is guaranteed to find it. That's what I told you. Dense glandular densities we can miss. If I had a normal mammogram last year, I don't need another one this year. It's again another myth, especially in the age group of 50 and above. And if my doctor didn't tell me I needed a mammogram, so I cannot schedule it. This happens when women in the 40 to 50 age group, when they come for an ultrasound and we try telling them mammogram would be a better modality, having come, please get it done. And then we will do an ultrasound also. It is complementary. Both in our center, what we do is we don't send any woman with just an extra mammography. They do not walk out of our clinic. An extra mammography is done. They are made to wait. We review the images. We do an ultrasound, and only then we send them out. No woman walks out of our clinic without an ultrasound after a mammogram. So when we try telling the patients, it's a mammoth task to convince them. I don't know what they think when we tell that, but we try to educate them in spite of all these things. Now comes the breast ultrasound. Why does it help in mammography? Is whenever we see lesions which we are not able to come to a conclusion whether it is malignant or benign, and when we do an ultrasound, it helps us to categorize the lesions in a better way. It tells you whether the lesion is cystic, whether it's a cystic lesion, or it is a solid mass, or it has ill-defined margins. And maybe in dense breast we can see one lesion, and ultrasound helps in finding out the satellite lesions that goes around with this. So that's the role of ultrasound. But it cannot replace X-ray mammography. As I said, mammography and ultrasound. And it can be the first imaging modality for visualization of the axilla. If enough axillary tissue is not included in the mammography, or certain times some obese patients come where technically it's not possible, then ultrasound helps in picking up the nodes that is available in the axilla. And of course, it is imaging guidance for percutaneous biopsy and localization of the lesions. So this picture is a picture of a 28-year-old girl whose wedding was fixed, and she just felt something was not okay, and she came to us. And this nodule, you see, it's a cancerous lesion. We picked it up in ultrasound. Then she went for an X-ray, and biopsy proven it was a invasive ductal carcinoma. And this is again a young individual who comes with a huge lesion. Earlier, we all used to report it as giant fibroadenoma. So that is not the case at all. Nowadays, according to Berat's, if you're not sure if it is a fibroadenoma, we put it in the probably benign category, stage 3, and do a short time follow-up, or straight away go for a HPE evaluation to see what it is. This girl, though it was reported as giant fibroadenoma earlier, and she had come after 6 months, we felt there was an increase in size. And when the biopsy came, it turned out to be phylloids. So there's straight away, if you're not sure it is a benign lesion, please, they need further evaluation, either in terms of follow-up or in terms of HPE. As I said, ultrasound guided biopsy can be done. And this is one more case. I thought I'll share some case histories also, because it should not be boring. So this is, in this, you see the left breast looks okay. This is the right breast where you see the lesion. Corresponding ultrasound was done and a mass was picked up. And the same sitting, ultrasound guided needle biopsy was done. See, FNAC can also be done, but certain lesions, biopsy will give you a better yield of tissue, and reports, the HPE can be better. In this lesion, it is definitely not a palpable lesion. So this would definitely need ultrasound guided guidance for biopsy. The newer technologies, as I said, tomosynthesis, MRI, and molecular breast imaging have come. MRI, yes, it cannot be the screening modality for various reasons. One, it is expensive. Two, the positioning of the patient, as we see here, they have to lie down in prone position with their breasts within the breast coil, which can be uncomfortable for many women. As such, MR can cause claustrophobia, and this position can add to more of it. So this can be utilized in patients with a high lifetime risk of breast cancer. So as determined by family history or BRCA mutations and other factors, and it remains the most sensitive method of detecting disease within the breast. However, it has lower specificity than mammography and results in more unnecessary biopsies if we just do an MR and follow it. And as I told you, it can cause claustrophobia, and availability of MR with the special coils and the expense are the limiting factors for having MRI as a screening tool. Having diagnosed a lesion, we spoke about it, how radiology can help. One is ultrasound guided biopsies, or FNAC can be done, or the other method is stereotactic biopsy, where we use the mammographic thing. It's a specialized mammography machine where the patient is lying down in prone, and the breasts are between the mammographic plates, and the image comes on a screen. This is specifically helpful in patients who present just microcalcifications and no mass is seen. Then a probe can be inserted, and then the area of microcalcifications can be sucked in and can be sent in for HPE. Now, this is very interesting mammogram. We spoke about all female patients getting CA breast and all those things. Men also have breasts, and they can also present with malignancy. So this is one such gentleman, 45-year-old man, who presented with a lump in his left breast, and this was the mammography done. So when it can be done in a male breast, it can be very well done in a female, and it will give better results. So the ultrasound of this individual, it was a microlobulated heterodense lesion and biopsy proven invasive ductal carcinoma. So this is one last video. With this, I conclude my talk, reiterating again and again that Mammography is the screening modality chosen, and no other modality can replace it. And it is the one which can detect lesions earlier before it's clinically picked up. So this video, and we conclude our talk.
A mammogram really is an X-ray investigation of the breast to look for a cancer.
But who should get a mammogram and when?
There's been a lot of controversy in the last 10 years about whether age 40 is the right age to start screening, and whether mammograms should be done every year or every other year.
Dr. Amy Degnam says mammograms have been proven to save lives by detecting breast cancer early while it's still curable. But the test is not always a perfect fit for everyone.
But a mammogram does not detect 100% of cancers in the breast. Some women who have very dense tissue in their entire breast, there could be a cancer in there that we just cannot see well.
In that case, or if a woman is at high risk of breast cancer, other screening tools such as ultrasound, 3D mammograms, MRI, or a technology called molecular breast imaging may be additional options. Women should talk to their healthcare providers about the screening tools that are right for them. For the Mayo Clinic News Network, I'm Vivian Williams.
Thank you so much for giving me this opportunity and for your wonderful and patient listening, all of you. With that, I'm done. Shanta ma'am. Thank you.
Thank you, Dr. Purnima, for a wonderful journey through all the modalities that are available. You've projected the mammogram as the diagnostic tool, the pros and cons of the situation, the myths attached to it, the role of ultrasound and MRI, and the molecular testing. Thank you once again for the snippets and case scenarios you have presented. It's a nice journey we have taken us through.
Yeah.
Can I make a request, Dr. Purnima?
Yes,
Can you make a survey of the IMA doctors who have gone through mammogram? And if you have not gone through, can you help us to go through the mammogram?
Definitely, ma'am. It would be a pleasure for us. Definitely.
Yes,
We're always looking forward to helping the society.
Yes.
Dr. Purnima,
Yes, sir.
I have a comment, and a question.
Thank you, sir.
Compliment is for excellent presentation.
Thank
the comment is the first video you showed.
Yes, sir.
It's a nice way of getting another selfie. The people are looking for that selfie, but the positioning of the selfie would be very important here.
Yeah.
If they don't position it, then it will give all sorts of abnormalities when compared to the other side.
Yes,
There is
sir.
one problem when they have to, like you see, so many photographs are being taken by people in odd situations.
Yeah.
Odd projections. So if that is what happened for a breast, it is difficult.
Yeah.
Second
Sir,
is
I know I was looking for something from the Indian side of aspect of it. I could not get. I would not even recommend a selfie. A good mirror and good lighting would be better for self-examination. But this video I could get only this.
Usage of the hand was not mentioned there. The flat of the hand was supposed to be used. Then the photograph was showing as if their fingers are dipping into the breast. So I think there was a little variation has to be made. So the question I want to ask you is,
yes, sir.
When the patient is coming to you for an ultrasound or a mammogram, you complement together.
Yes,
Do
sir.
you do an examination before you do these procedures?
Definitely, we do an examination.
And
sir.
do you put that on record? Because why I'm saying is many times the patients call up the doctor and say, I've got some problem in the breast.
Okay.
Problem. It is only a pain or some heaviness or something.
Okay,
and the
sir.
doctor immediately says, go to Athena scans, get a scan and come back.
Okay.
Without examining.
Okay.
There the question, the entire thing depends on your clinical examination than the doctor who has never done this clinical examination.
Okay. We
Or
definitely.
otherwise, what happens is the doctor sees the patient. Most of the doctors, they don't record it in a diagrammatic way or whatever. Then they come to you for a scan after a month or two, and you give a report. And again, the problem is depending on Purnima's report only, and the clinical examination doesn't correlate or never correlates.
Okay.
So if you can put your clinical examination in the record, in your radiology record, will that be unlawful?
Definitely not, sir. We do write the clinical history. We have not recorded the clinical findings that we do. We have not written. We can definitely write. That is a good point. We assume when the patient comes to us, either they have come in this pandemic situation, they don't get to see the physician. Otherwise, mostly the physician or the surgeon has examined the patient and then they come to us. So we take, and whenever there is a discrepancy between what the clinician, the referring doctor has and we have, we always pick up the phone and talk to them directly. So, and we are always open for suggestions from you also, sir, in case.
So you tell me honestly, how many doctors have given you a request saying that there is a lump in this position? Have you ever received they say lump breast and it is given to you, or thin breast? That's all. So
Yes,
there
sir.
is no question of correlating your clinical finding with the doctor's clinical finding.
Okay, so we have not put it on records. Maybe here afterwards we'll follow it. That's a good idea to do.
No, I'm just putting it across. I don't know whether it is lawful or unlawful. I don't know.
I don't think so. Anything is unlawful. Let me also check it out and then take it forward, sir. Thank you for the suggestion. Yeah, thank you.
Thank you very much, Purnima.
Thank you, ma'am. Thank you so much for giving me this opportunity. Thank you.
The next talk is The Standard of Care in Breast Cancer by Dr. Somashekar.
Thank you,
Will you
madam.
say a few words about it?
Good evening, everyone. I once again take privilege in introducing my colleague, mentor, and who's been associated with many academic activities of ASI, other, whatever there is a student education program, Dr. Somashekar kindly contributes for it. Now, as a matter of respect and protocol, we'd like to introduce Professor S.P. Somashekar, sir, to all of you. Professor S.P. Somashekar is the current president of the Association of the Breast Surgeons of India. He is the director of oncology at Manipal Comprehensive Cancer Center, Manipal Hospital, Bangalore. He is member of the MHB Medical Advisory Board. He is member Board of Studies, Manipal Health Board, Manipal University. He is an adjunct professor surgical oncology, Manipal University. Dr. S.P. Somashekar was born in Sampigi village in Tumkur district, Karnataka. He did his early schooling in Chitradurga and Davangere, and later studied at STJ Anubhava Mantappa, where he received a National Merit Scholarship. He did his medical schooling and graduation from Mysore University, JJM Davangere, and subsequently through an All India National Competitive Exam, he did his Masters in General Surgery followed by Super Speciality in Surgical Oncology from Ahmedabad. And he stood first in the university and he was awarded the University Gold Medal for his MS. He then received fellowship of the RCS Edinburgh, followed by multiple clinical fellowships in USA, Paris, Taiwan, and Korea. Dr. Somashekar is the chairman and head of the Department of the Surgical Oncology at Manipal Health Enterprise Private Limited and is best known for performing the highest number of robotic complex oncosurgeries in India. He is credited with setting up of HIPEC and PIPAC program in India and for heading the largest HIPEC program in Asia. Dr. Somashekar was also the first to perform the first sentinel lymph node biopsy procedure in India and implemented artificial intelligence technology for breast cancer management. Manipal Hospital have become the first in the country and second in the world to implement the IBM Watson platform for oncology and AI technology for diagnosis and treatment of cancer. To tell a brief way, he has had plenty of awards, which runs to many volumes. And to comment his important training centers, he has been trained at the University of South Florida, Tampa, Todd Cancer Center, Long Beach, USA, and had done robotic thyroid surgery fellowship, Seoul, South Korea. Now, on behalf of the IMA, I take the honor of inviting Professor S.P. Somashekar, sir, to address on this important meeting of the IMA Chennai South to celebrate and commemorate the October Pink Awareness Month of Cancer Breast. Over to you, Professor S.P. Somashekar.
Thank you very much. Thank you, Professor Kanagvel, for excellent and such kind words. It's my honor and pleasure to be part of both this Pink month in October, which is not just awareness, prevention, education, but also getting a knowledge among common public, people, patients, doctors, and healthcare workers. Thank you very much, IMA chapter, and it's my honor to share. What I have done is I've kept my talk little short, but everything based on my personal research experience publishing in international journal, which is relevant to India. I have put it. What is most important is when I was in UK and then when I did my breast surgery fellowship in Maggie Women Hospital, Pittsburgh University, we used to always think, it is the era of maximum tolerable disease. If you speak about any cancer, people are more scared of treatment than the disease. You ask any lady why you are coming, they say they will give maximum surgery, they will remove my breast, they'll give radiation full body, then they'll give a lot of chemo, I'll have a lot of side effects. so much of problem will happen with treatment that maybe it is more tough than this. This was a misnomer people had. And, we can't blame them because 2 decades ago, the plan was the disease is so bad, maximum treatment was given. But now we understood that this is an era of de-escalation, surgery, radiation, chemo, cosmesis, minimal access, breast preservation. All of them have moved from maximum to minimum effective treatment. We no longer do maximum. We now know with science and evidence what is the minimum that is required to do the right thing, keeping oncological principle, achieve the same cure rate, yet give a lot of importance to quality of life, cosmesis, betterment of patient. So that's why we moved from removing the breast to breast preservation. Similarly, we moved from removing all the lymph node in armpit and axilla, causing lymphedema, Halder problem, to minimal access. So this is an ideal line. Don't do any treatment above the line and don't go below. If you go above, no benefit to patient, lot of complication. If you go below, you will end up with recurrences. So this is the main persons, 3 persons in the breast cancer history. Halsted, who is a great surgeon. Fisher, who is a scientist, who is the father of NSABP, who did a lot of NSABP trial and made us understand where to use hormone therapy, where to do breast conservation, where to give chemo. And then the Giuliano, who invented the minimal access surgery sentinel node. So this is very important that, we don't do advanced unnecessary surgery. On the contrary, we don't become very, very low conservative. Like if we have a 1 centimeter breast cancer, if I keep the hand in the armpit and tell, oh, there are no lymph node, my ultrasound is fine, so let me not check axilla, it is dangerous. Because even then there is a chance there could be microscopic disease, and if we miss that, we may undertreat them. The problem in cancer is we overtreat the low risk and we undertreat the high risk. So because we overtreat low risk, cure rates are not changed, only they accumulate baggage of complication whole life. In high risk, we undertreat, so they recur and then we blame the disease. So it is doctors to blame. So we need to understand the oncological principle that Halsted theory told that the disease is loco-regional, but Fisher made us understand even in early cancer, you need combination of multi-modality treatment, systemic therapy, hormones. So even though what it appears to be early stage 1 still have chance of coming out. So we moved from Halstedian theory to Fisher hypothesis. Second thing we understand is I authored a big publication last year, which we brought through Association of Breast Surgeons of India, published in Springer Journal of Oncology, that we always say in India, women come late, LABC, we can't do breast preservation. No longer, we cannot hide behind the disguise of that. Last year, we published the census of the breast conservative surgery percentage across India, not just private or this one. In government center, people who are coming to regional cancer centers, and you will be surprised to know across all the centers in India, rural, urban, more than 56% is the breast conservation rate. Now, no longer LABC is the commonest. LABC is now 30%. 40% of women now are coming in stage 2 or early 3A. And then in selected cases, 60 to 70% breast conservation is there even in government sector, which means more and more breast preservation is happening. The commonest reason surgeon was not able to prepare, do breast conservation is accessibility to radiation, and then the breast and tumor ratio and residual. If you remove more, less cosmesis, chance of coming back is less, but if you remove less, cosmesis is better, it recurs. So that is where a huge era of oncoplasty started. If you remove a lump, you close it, you'll be a fool's paradise thinking it looks normal, but see the same lady after 6 months, once the seroma is absorbed, everything is puckered. Better to do a good mastectomy and give flat chest than a badly performed breast conservation. That's why surgeons should learn this law. If you remove less than 20%, no reconstruction required. If you remove 40 to 60% volume, you need to do breast local oncoplasty, rearranging of the breast tissue. If you remove more than 70, you need to do a flap from outside. So that's why this is the general principle. This is a small ray diagram I have done. Don't put unnatural incision. Placing a right incision is most important. Remember, you remove in a conical shape. The nipple areola will move, symmetrize the nipple areola, and then move the glandular flap. So this is called as Krishna-Claus role of oncoplasty, level of oncoplasty 1, 2, 3. Always oppose the breast glandular flap, cover it. If you leave a cavity with seroma, after 3 months, when the fluid is absorbed, it is bad. So now we understood Krishna clause level 1, 2, 3 oncoplasty. So remember this, you remove the tumor, mobilize the glandular area, close it, relocate the nipple areola and look at, and these are all daycare procedure, no plastic surgery is required, you learn yourself and look at the result. After radiation, 2 years after that, still there is a very good cosmesis. Even a big tumor like that, you remove it, mobilize the glandular, type 2 Krishna clause, relocate the nipple areola. This is called as Benelli donut type. You go double donut around the nipple areola, remove this area, go to the primary tumor, excise it with a negative margin, oppose the glandular pillars, mark the lumpectomy bed. Look at this. This lady will not even see a scar after that, but you adhere to the principles of oncology and a sentinel lymph node. Second thing is, this is something new which has come. Now it is available in India. You know, this is called as Biosorb. It comes with a small coil of various sizes, which has got 6 titanium clip integrated. After surgery is over, in the lumpectomy bed, you put this like this, oppose the glandular tissue. After 3 weeks, the whole thing is absorbed. Only 6 titanium clip are left at the border. And imagine now, when the radiation oncologists take a scan, look at this, how it is looking. They know where it is and you can do. This is called Biosorb. It is available now. We routinely use it. So you do a breast preservation, drop this there, the filament part get absorbed, and then after that only clips are impregnated. It shows very well where is it. So this is a Biosorb 6 titanium clip. It's one of the standard of care now in breast conservation to give a good boost. Second most important thing is managing the axilla. Remember, axilla is like a holy grail. Even when the tumor is 1 centimeter, 10 millimeter, there is a 25% chance cancer may be there. So you can't say I will omit the axilla, and you can't do sampling. It is not an adequate way of knowing it. If you do a good axillary staging, positive, higher stage, chemo radiation required, negative, no need to remove, so no lymphedema, shoulder problem, and you can de-escalate the treatment, which is very, very important. But if you blindly remove all the lymph node, only 30% is benefited, 70% will not benefit, 50% will end up with complication. What are the complications? A woman who is cured of breast cancer herself know what is the debilitating problem of lymphedema, intercostal numbness, shoulder problem, paresthesia, lot of seroma, keep aspirating, keeping drying, prolonged hospital stay, delaying the chemo. And this is permanent, debilitating, no permanent treatment for them. So complication of axial lymphadenectomy should be avoided. And the answer for that for you to know is to know sentinel. What is sentinel? If you go to old forts, Maharaja Rajas, there is one big pillar at the entrance of the gate. At the top of it, one soldier is sitting. That guy is called sentinel. He can look through 5 kilometers away and he can see if the first army is attacking and he can give a warning bell. That is the name of sentinel. That is the first warrior. Every breast, be it wherever be the tumor, which quadrant, there is one sentinel node for that patient in axilla, which will be the first node to drain the cancer. If that node is negative, then all other nodes are negative, no need to remove. So, but you don't know how to do the sentinel lymph node. There are enormous hundreds of trial now, high level evidence, which showed that sentinel lymph node is now the standard of care, very standard of care to do it. So the ASCO told, in this era, in stage 1, stage 2, if you don't offer sentinel node to women, it is crime. It is a gold standard. Very rarely we use the term gold standard in medicine. Remember, gold standard, standard of care, both are different. To achieve to the level of gold standard, multiple level 1, multi-institutional randomized trial across various countries in various patients should be proved. Last 20 years, this stood test of time. So sentinel lymph node is called the gold standard now to assess, and there are enormous amount of study. And you know, these were very expensive methods. Way back when I did the first sentinel node, then I published the first study in India with Indian available methylene blue, which is few hundred rupees. This is a study published, you can go back and see, which showed that make in India, made in India solution for Indian problems, which we published. So the sentinel lymph node should be now offered to all breast cancer, which is clinically and ultrasound axilla negative, any tumor up to 5 centimeter tumor. And now American College of Societies showed that before doing it, first 20 cases, your pathology, nuclear medicine imaging should do. false negative rate should be less than 5% for you to do. There are so many trials, I'll not bore you, Indian trials, American trial, UK trial, which showed if you do sentinel lymph node, the chance of axillary recurrence is 0.3% only. So now it is a very high level evidence. There are various ways you can do. You can put a blue dye, you can put a nuclear technician scan and do it. There are so many dyes available. It doesn't matter which dye you use. Even a methylene blue, which is available, which we use in intensive care to treat methemoglobin poison given IV, is equivalent to all of them. And this is a study which we showed how a sulfur colloid with methylene blue is same, and you can use the same one. From Association of Breast Surgeons of India, we don't want to follow what Americans did, UK did. That is not applicable to us. It's a fashion to see what Western world did. No. Indian solution for Indian problem, made in India solution. We brought a consensus, practical Indian cancer directed recommendation, which is a very super hit, and it is available. All of you can go back and read. It's a 10-page recommendation from ABSI, how to practice breast cancer in India, rural setup, medical college setup, tertiary cancer center. And this is the paper which we analyzed recently, which showed breast conservative rate even in India is very high. And this is a machine which we made in Bangalore, CE approved, very low cost, and this is high CG fluorescence image made with the help of IIS Bangalore, and which uses this dye made in Coimbatore and Madurai, available in few hundred rupees, where you can give this dye. You don't need nuclear medicine, big cancer center, in medical college setup, rural setup. You can give. When you give behind the nipple areola, can you see that how the sentinel lymph node fluorescence? Advantage is very easy. 8 minutes you can know after induction. No nuclear medicine doctor, no nuclear medicine therapy, very cheap, very easy, no anaphylaxis, can be done everywhere available in India. We did a first concordant study in Indian patients. We published this in an Indian journal, presented in US San Antonio, got a best paper award. And then we went on to do the first prospective double arm study. It is so easy that this is available in India. You can connect it to your laptop. This dye is made in Madurai and in Coimbatore. It comes in a powder form. You reform with 2.5 milligram per ml. Then you just put 3 ml, of this behind the nipple areola complex. And once you do this particular dye, you can see that you can just take this, inject it, real time in front of your eye in seconds. That fluorescence goes through this, stops in the axilla and the armpit, and then you can easily mark where that particular node is. When you put a small dedicated incision in the axilla, you can pick up this node and see, even before you keep an incision, it shows where that node is. So then the fluorescent sentinel node, very easy to practice. We through ABSI have done a lot of skill course across India to train. And then when you send this particular node, see this primary and the lymphatic fluorescent and the sentinel node, very minimal mistakes, very easy to practice, very fast. Nipple areola, and then the lymphatic travels and the sentinel lymph node available, very easy to practice. We did this first 100 patient study, the best journal for the breast cancer in the world, the Clinical Breast Journal, top journal of Association of Breast of US, published our study on a rapid, which showed that it is far superior to any other modality of handheld gamma to do. Now totally we are replaced this. Even if you have a big tumor, you're given a chemo to downsize, neoadjuvant chemo. Now there are 2 large trials which is showed, as long as you can clip that sentinel node with a clip with help of intervention radiologist, you can still go ahead and do this. The last few minutes of my talk is, this is now the standard of care. Other day, Professor Kanagavelu was discussing with me, in all cases of breast cancer, when we address the axilla, we get lot of seroma, big nuisance for a woman. They stay in hospital, drains, infection, delay in radiation. How to overcome this? This is a very important chart I borrowed from one of my friends from Australia. If you do lymph node dissection, look at the chance of lymphedema. If you have done a lymph node dissection and the patient required radiation, look at the incidence of lymphedema. Even if you have done sentinel lymph node, if RT is required, look at this chance of lymphedema. And if you have done sentinel lymph node, no RT is required, which means the lymphedema is lowest if you do sentinel node, highest if you do ALND with RT. How to overcome this particular area? So this is a new technique, that machine which I showed, made in India for us, we normally give this small, ICG, which is a fluorescent dye at the first web space. And then we use this camera in front of your eye, this lymphatics goes down. Any patient who has undergone any surgery for the breast, we do this called a lymphedema screening. Every week in our hospital, we have a lymphedema screening day. And then you can see that these patients undergo this screen. We follow the lymphatics, whether they go and drain to the axilla or they are lost. And based on this, we have 4 patterns of lymphatics. You can see this is totally very bad lymphedema, patchy, starry eye appearance, no way it can be done. So we detect 4 patterns: linear, splash, stalders, and diffuse. And the treatment for all of them is totally different. So what do we do? In my hospital, when we do sentinel node, if the frozen comes positive, I have to do complete axillary clearance. Immediately on the table, when the patient is under anesthesia, we give this ICG. Now we just use that handheld, indigenously India developed. In the axilla, you can see where is that leaking lymphatic. That lymphatic will leak 100, 300 ml of lymph for weeks together. Now we see that lymphatics. Now we just drop it into the neighboring small vein there. It takes 32 minutes extra daycare procedure along with breast conservation sentinel lymph node. Now that lymphatic is going to leak and cause lymphoria every day. Now, if you just take this particular axillary thing and then you drop it back to the vein there, which is available easily in the lymph node, you can see this is called a lympha surgery, primary lymphovenous anastomosis during the surgery. And then you complete this, you will suddenly see that all the fluid now is going into the vein. And we again give an ICG and you can see no longer now leak is there. These patients drain, come out in 48 hours, even if you have done axillary clearance, they don't develop lymphedema. So this is one of the standard of care now that is coming. Unfortunately, if they've undergone surgery elsewhere very late, many years later, they come, already lymphedema is sets in, then we use this, we harvest the lymph node from the groin. You can see that we harvest the lymphatics and the lymph node with the groin. We put it back to the arm. Now this acts like a pump. All the lymphedema is drained and within 2 weeks, the arm becomes normal. So this is called as lymph node harvesting surgeries. Now this has become new standard of care for us in this inbuilt with the sentinel lymph node breast conservation. So this is something which is very important for us to understand. So now you can see that how sentinel lymph node is revolutionized. Even if sentinel node is positive, if they fill into the ESOCOG Z11 criteria, we can omit axillary clearance with that. So now this is an era of daycare breast surgery. Knowledge, woman undergoes breast self-examination screening, breast preserving surgery, sentinel lymph node, lympha surgery, daycare discharge. Excellent quality of life. Now in breast cancer, we don't say 5-year survival, 10 to 20-year survival. And remember, surgeon is not the alone guy. If I say I, me, myself, then we are the biggest fool. Surgeon is a minuscule part of treatment of multiple in the breast. It is the breast imaging specialist, the radiologist, counselor, breast survivor group, the breast nurse, breast pathologist, and the patient who selflessly trusts all of us and subject. So breast cancer now is like a chronic disease. No longer it is great if you say I cured them. Cured without complication, going back to normal life with dignity and preserving with cosmesis. So it is a multidisciplinary team. The event like the IMA from you, we are doing it, taking all parts of life of people, imaging people, great doyens like Shanta Madam, who are dedicated their life to breast care of India. And then, who are biggest awardees of the national, international, the patient advocacy group, the imaging specialist, the nurse, psychologist, then minuscule part of us like us surgeons, coupled with imaging medical onco, all of them are giving cure now. So now remember, it is not maximum tolerable treatment, minimum effective, cure rate same, cosmesis better quality of life. Remember, more is not always better in life. Less is not always inferior. Era of de-escalation, era of reaching your target organ fast, quick, with least money spent, with patient being the main driving force and alone, their outcome as the only goal and no other factor coming into play is important. Thank you very much. That is my lovely wife and both daughters, who are all traditional Bharatanatyam dancers. Thank you.
Thank you, sir. That was
yet another edition of your excellence in teaching us. In fact, I, on behalf of IMA Chennai South and all the leaders here, I express my thanks. I'm sure you will have questions. We have the National President-elect of IMA, Dr. Jayalal sir, is with us. Our president is there. Incidentally, many surgeons are there in this group. Many obstetricians are in this group. So I am sure we'll have more questions. Dr. Jayalal sir, please. Sundaramati sir, please.
Dr. Somashekhar.
Hello, sir.
Sorry, sir. What is your experience on the breast cancer in the male and transgenders?
Yes, sir.
Yes, sir.
Sir, I have operated total about 67 patients in last 18 years at Manipal Cancer Center.
Yes,
I
sir.
get about 3 to 4 patients. Even though we say that, cirrhosis of liver, Klinefelter syndrome, testicular problem, drug-induced is more, most of these people didn't have any of this risk factor and it was idiopathic in them. Most of them were at their 60s. 90% of them were estrogen receptor. About 40% came, unfortunately, in locally advanced breast cancer. But the result in them was good because they were all ER positive and they could actually undergo good treatment. So I have patients followed up for 20-25 years. But one interesting thing I find is half of my patients were of very high strata economic, IAS officers, ministers, very social, intellectuals, and then, press reporters. So somehow the male breast cancer result was little better than female, unlike our initial belief. So now I routinely tell them that, even though it is about 3 to 4 per year I operate, it needs to be aware. That's why it is very important to know that the pink ribbon is never pink. If you go back and see the pink, at the end tip of it, it is actually purple, bluish purple, because the WHO motto is breast cancer do happen in male. It is never pink. If you see that it is not pink, the last tip is purplish blue, which suggests male cancers do happen. So if we catch the male and tell, look, you too have, then you use them opportunistically to bring awareness in their wife, mother, sisters, and then they actually will promote the family to come back.
Thank you, sir. What about in transgenders, sir? Transgenders.
Yeah, I have never operated a patient with transgender, sir. Maybe.
Thank you, sir. Thank you. God bless you. Thank you.
Thank you, sir.
Dr. Jayalal sir.
Yes.
Dr. Devaji sir.
I have to only compliment for the to the point lecture. I have no questions at all. Everything is 100% clear.
Thank you, sir. Thank you.
Dr. Somashekhar sir, I would like to have a couple of questions to you. Number one, it looks like if you're going to have the ICG as a tool, it gives a lot of comfort level to the surgeon. Are we doing adequately? Are we removing all the nodes which are yet to be cleared? And sir, being an indigenization and make in India, it should not be very expensive. How much is the cost of the equipment, sir? And how long somebody needs to get trained to use this equipment safely, sir?
Now, if you see the handheld gamma probe, which we use to do the sentinel lymph node, its purpose is only one, sentinel node, nothing else. That is typically 36 lakh rupees. And yeah, any handheld gamma probe, the Johnson & Johnson, Europrobe, Neoprobe, there are 3 companies. They are in the tune of about 28 to 36 lakh. Now, the German-made ICG probe from the Stryker ranges from 75 lakh to 1.2 crore, which is available in India. Now, this probe, which is developed, approved now by Indian authorities there, and 23 cancer centers in India have after my study, and I have 2 of them. I use it for sentinel lymph node in breast. I use it for sentinel lymph node in gynae onco, vulva, penile cancer. My plastic surgeon use it for flap viability. You harvest a flap, give ICG, and look which part is not good, you trim it. You're doing a tram flap, give ICG, use this, which part is there, cut it. You've done a MRM flap, before closure, give ICG free, and then give this one, and this flap is not good, revise it. You've done a penile block dissection, you give ICG, flap is not there, revise it. Abdominoplasty, revise it. Colon, LAR, you want to do anastomosis, you know where to place the anastomosis, you can use it. Microvascular flap, you use it. Lymphedema surgery, use it. Everything is one. It is available anywhere between 10 to 15 lakh rupees. That's the only investment. which is one time, and the dye is available in India, made in Coimbatore and Madurai. So the experience is about 7 to 10 case, one surgeon learns, then it is very easy to do it. A small skill course of 2 days, all of them have practiced in India themselves. Through ABSI, we do skill course to train people in this.
Thank you, sir.
Radical mastectomy has gone out of the practices.
Now, 2/3 of surgeries are breast conservation. Radical mastectomy is in very limited patients who don't want to take radiation, or they come in very, very advanced state, or they cannot be downsized. Even in Tata and then now Adair and Ames, where very, very low poverty patients come from outside, now more than 60% is breast conservation, even in rural background. So now the norm is organ preservation, and ablative surgery is less and less is required in oncology.
Thank you.
Dr. Jailal, sir.
So thank you very much. It's nice to see Somaseka sir once again, and it is good. And I must congratulate South Chennai for taking up the issue. I mean, definitely IMA will be in the forefront in taking up this issue of breast cancer awareness among the public, and we will do maximum to create a knowledge-based enhancements of these ideas and inputs. I'm so thankful to Somaseka sir and Devaji sir for updating in a very beautiful way. It is rare lectures we are seeing in the Indian Medical Association platform. It is a nice, sir. So thanks for Kanagavel sir bringing all these people, and South Chennai Santanarayan madam for organizing it in a way. So congratulations to IMA for that.
Thank you, sir. Sir, what I believe is, I don't believe to speak from somebody else's experience downloading slides from some other. I normally speak only from the research study I have done in Indian patient from my work published in international journal. So otherwise, rest is theory. Anybody can nowadays go on Google and read it.
That's fine, sir. Exactly, that is all right.
That is why this appreciation, sir.
Thank you. Thank you.
Thank you, Dr. Somaseka sir, for sharing this afternoon with us amidst your busy schedule. Thank you so much. We look forward to have more academic collaborative programs in future. Thank you, sir. Thank you so much. Shanta ma'am.
Our next program is the newer options to win breast cancer by none other than Kanagavel sir. Yes, sir.
Thank you, ma'am.
Yasoda? Yes, Dr. Kanagavel, let me first thank you profusely for bringing a plethora of speakers today. You have elevated the level of CME program of IMA Chennai South to the next level. So Dr. Kanagavel is not new to any one of us. Let me say a few words about him. He is the senior consultant and PG faculty in the Department of General and Gastrointestinal and Minimal Access Surgery convener in Isabel. He is the convener of regional appraisal and formative of DNB postgraduate at St. Isabel's. He is the founder and director of gastroenterology, laparoscopy, Adair Institute of GE, Adonis Obesity and Metabolic Surgery Center at Adair. An alumni of the Kilpack Medical College, he has got his DNB, MRCS Edinburgh, fellowship in laparoscopic surgery, bariatric surgery, abdominal wall hernia, endoscopic surgery. He is a PhD scholar in post-surgical quality of life issues in cancer esophagus. His publications are innumerable. I wouldn't be able to complete the program if I start reading it. He has even done a COVID-19 endoscopy of the recent pandemic. He has contributed to many textbooks. To mention a few, Modern Approach to Corrosive Injuries, Video Atlas on Surgical Technique Esophageal Replacement, Conduit Management in Esophageal Replacement Surgery. Over to you, Dr. Kanagavel.
Thank you, Yashoda ma'am, for kind words on me. I thank the President, Secretary for allowing me to present in this esteemed platform. With the permission of the faculty, I'm sharing the screen. I'm sorry. So I'll be touching upon something very important, and people may find I'm talking a little out of the platform, but then this is how the focus of breast cancer therapy is going to go upon. So I warmly thank once again IMA for this giving this opportunity during the cancer breast awareness program on behalf of the Chennai South. And yet again, our IMA is as good as an extended family of us. See fighting all of us, but still we remain as a single big glorified family. So there have been always the seniors who have been kind enough in correcting youngsters, putting them, aligning back, and restoring normalcy at the earliest possible time, even if there is a disharmony. But then I thank Lakshmi ma'am, Shanta ma'am, Devaji sir, who brought into the EC and in the ambit of Chennai South. And I also thank the state leadership who has been very kind in joining us in encouraging us in all the program. Our state president is now escalated to national vice president, and we look forward to have a wonderful tenure with the incoming president-elect also. And on behalf of the IMA Chennai South, we warmly congratulate the seniors who got escalated to the national platform. Professor Kailash sir, who has become the national president-elect, and we have Dr. C.N. Raja sir, who has become the national VP. And we also have our Dr. Anbarasu sir, who has become the honorary secretary of the IMA CGP headquarters for 2 years, that is 2020 to 2022. So I is contemporary, even today it is valid. It has a low therapeutic index. I'm sorry, I think I lost you for a moment. 1 second. Am I audible now, Devaji sir? Yeah. So now all of us do understand it comes with a low therapeutic index. Low therapeutic index means it does work, but what is the predictability? Are we giving durable cure? Those are the questions which are being challenged. And you still are not able to predict or answer to your patient, sir, am I cured of, will I be cured of the disease? You may verbally as a doctor to give the comfort, you may say, yes, you'll be cured. But verbally or mentally and morally, you know, there are many areas which are uncertain in your mind to tell the word, yes, madam, you're going to get cured. That is a challenge all of us are now facing. 1 second. And breast cancer is not a new disease. It is the earliest evidence could see from the replications of the artwork, both drawn art as well as the hand sculpted arts of the Renaissance period. One could see the puckered breast and one could see the nipple retraction and the advanced nature. On the left, one could see the women having lymphedema with little bit of darkening. On the lower inside, you can see the inner lower quadrant. But I'm not sure whether the sculptures took time to understand what they are drawing. But then we could understand the diseases were existent, diseases were fairly advanced from these artwork. The most common challenge or most common thing what we tell to the patient is, today IMA has taken so much of efforts, starting from Shanta madam to the entire speaker fraternity, have imported the importance of having a screening program, yearly checkups. So you pick up the disease than the disease picking up you with advanced signs and symptoms. But then somebody has done a very detailed work. If you go through, see, a woman has to go through so much of complex environmental things and so much of complex understanding of the situation before eventually to have the first contact with the healthcare professional. See, for instance, healthcare infrastructure, unfamiliarity, fear, how difficult it is to take an appointment with the oncologist or a surgeon, and then as they come down, what is their relationship with healthcare professionals? And on the other side, cost of healthcare services and personal beliefs. They have their own religious belief, previous deaths in the family. They know, they at least partially believe it becomes incurable. And then their own personal obligations of child care or work-related ailments. And more than that, the emotional and psychological, and then their personal what to say, experience of signs and symptoms that makes them more and more scared. So it becomes a very complex thing why a woman reports to the medical fraternity late. Most of the time, our Indian women end up having challenges reporting late. It is not because of their delinquency or laziness. It has a so complex interplay of affairs why they come to the hospital late. Then we move on to something. So people may ask me why somebody gets a breast cancer, why someone does not get a breast cancer. Please understand the fundamental understanding of today's sciences. Breast cancer is an inflammatory disease. It is as good someone getting stroke, someone getting coronary artery disease, someone getting myocardial infarction. It also follows a common inflammatory pathway. So the lifestyle disorders of smoking, work stress, or the type A personalities, lack of physical exercises, and certain set of trans fat dietary habits all contribute as equal to a coronary artery disease or a cerebrovascular disease or a neurodegenerative disease to the CA breast. In one word, ischemic, cardio-cerebrovascular, and neurodegenerative diseases have similar contributory factors to CA breast. Then let us talk little about the women. Today we had Dr. Mrs. Ramamani Ravi, who spoke very eloquently, and we had the teachers and the students coming up. But then, if you ask the person who has been told that you have a cancer breast, one could appreciate that is the most difficult moment for anybody's life. It is like as if you are told that your date of death is coming up. So they get demoralized, they develop various forms of fears, and they think about a lot of maladaptive rumination, and there is a physical thought suppression. And then, so you can see this is a sort of a water spout which is approaching a calm sea. That means the huge turbulence is going to be expected, and how you are going to cope up. That is where the medical fraternity come in. They make meaningful moments in the disease path, thus revealing a diffuse ambivalence between looking forward and facing the situation, remembering the pleasant ones, minimize the pain, and then many times when somebody really relives the trauma of disease, it is much relieving. It is like a breast beating when somebody dies at home. So reliving the trauma of disease relieves the burden of this patient. So with that background as a thought process to platform for me to work on, the previous speaker and the previous speakers all talked about the that day by day reduction of the requirement of surgery. So now we are going to touch up, are we going to do a breast conservation whereas a conventional radical mastectomy? But then please be aware, whenever you are going for high-end work, breast conservation or surgery avoidance as such, compared to a conventional mastectomy, sometimes when we speak about the setup where the patient is coming from and the compliance levels, still mastectomy is a very clear say. Ultimately, it is a survival and it is a cure what we offer, at what cost it matters. That is where in the availability of facility, in the make in India or make abroad, but then if you have the availability of precise imaging, you have the respective specialists, and you have the pathology beyond the hematoxylin and eosin, the surgeon as well as the patient to make a very clear informed decision to take for surgery or away from surgery. End of the day, we have to excuse me for a moment. So end of the day, we have to take a call. Will still be a part of breast cancer treatment at all in the future? But I would say, as Dr. Someshekar sir was very clearly telling, at point of time, we have only 30% of them coming with LABC, that is a locally advanced breast cancer. In future, the trials of surveillance for no surgery in ductal carcinoma in situ, already we have 3 major trials telling if they are picked up very early, if they are limited to one of the ducts of the lactiferous duct complex, then I think only neoadjuvant or only treatable or curative systemic therapy is sufficient for these patients rather than subjecting for a very disturbing mastectomy. Then we move on a little bit to more technical things. Lipid influence have been very clearly understood. People who use excess of trans fat, people who use increased fatty food, especially the unsaturated polyols. See, when there is an influence on certain diet, in breast as such, you have the epithelium, you have the stromal tissues which intercommunicate, and the adipose tissue which forms the formative aspect of the women breast. It has influence on all these things. People certainly believe it's only the diet which is going to trouble them. But if you feel, somebody who's into the molecular biology will be able to understand the intricacies, it is error in the fatty acid uptake and the transport biology, essentially mediated by CD36 and aquaporin 7, and then lipolysis and peroxidation are gene dependent. So in general, to put up in a nutshell, a healthy breast has so much of interplay. It is not only the estrogen and progesterone, it is a huge interplay of multiple factors, of which lipid deficit carcinogenesis. Then the next important challenge, what I'm going to tell may definitely disturb few of you or many of us who are practicing physicians and practicing obstetricians. Manipulation in the form of oral contraceptives. Initially, they claim the use of higher dose of combination pills alone cause or contribute towards breast cancer. Now it is very clearly understood, higher or lower dose immaterial, they definitely contribute to a marginally higher biological increase in occurrence of breast cancer. To simply tell, one extra case of 7,690 case of breast cancer occurrence happens because of hormone manipulation. The next question is, are we safe over low doses versus high dose? At this point, it is marginally safe, but over a long period of use, especially if it is using more than 5 years, or if it is used more than 10 years, then comes the problem of someone has a habit of repeatedly unmuting this, so probably it happens by itself. No worries. So now we move on to the subtypes. See, not all hormone receptor tumors are caused by oral contraceptive. See, they are ER, estrogen receptor, progesterone receptor, and various other hormone subtypes receptors also, of which we will go to the cancers are more influenced because they are the ones which are aberrant, they are the ones which are not going to respond, and it directly means a short-term few-month use is definitely less key over a period of time where women use for 5 years and 10 years. But be aware, whatever I'm talking is going to be very marginal, but this message is only for the medical fraternity, not for the press or the surgical, like lay people. Whereas it is very, very clear, use of low dose hormones or hormone manipulation are protective in endometrial, tubal, and ovarian cancers. So be aware in mind, we lose something, we gain many things. Then the most important challenge people are now facing in India, especially in Chennai, Bangalore, and other cities where have the software companies or other multinational companies who contribute to workforce of the various time zones. The next important question is, doctor, I'm doing night shift. Will I have an increased cancer risk? So it is a very well performed study which has been done over a period of 17 years. One could see a lakh and two, almost I would say 1 lakh plus patients which have been studied over a period of 15 years in UK. A mean average follow-up is 9.5 years. Of 2,059 patients developed breast cancers. See, these are all women in the reproductive age group and in the perimenopausal group. So they say it's comparable incidence when compared to a non-night shift working group. Then the next important challenge, this is going to be something very, very revolutionary, at least in another 5 to 7 years. All of us solved by
Kanagavel sir, you're not at all audible. The voice is breaking. So your voice is completely gone.
am I audible, madam? Hello?
Yes, sir, now. Yes, sir.
It's better.
Yes, no.
I'm sorry. I had to get disconnected.
Anakvel, konjam disturbance, otherwise okay.
Okay, sir. Okay, sir. So now we touch upon, I'll briefly go back to this topic of lactation. Lactation is protective. Longer the lactation, number of parity increases the safety survival. But here, the most important thing one has to understand in any woman who has conceived, given birth to a child, has completed the breastfeeding, the involution part of it. So what happens is, moment the weaning is stopped, the involution begins as early as 48 hours. In some women, it stops or the lactation stops in 3 months. Some goes up till 1 year even after stopping proper lactation. But again, one should understand this involutory process is such an exceptional process. A very active lactiferous duct, a very lactiferous complex which works in unison, responding to many hormones, let down reflex, suckling reflex, so many reflex, is most important ones are the type 1 and the type 4 lobules, where one could appreciate the COX-2 mediated inflammatory pathway plays a very important role. And I'm sure these are all now in studies. It's going to be definitely a very different outlook of how people are going to approach breast cancer in the coming 3 or 4 years. Then, Madam very, very eloquently spoke about from conventional mammogram to 3D mammogram. One could appreciate the conventional mammogram here. When it goes to 3D mammogram, how well it is seen well. I'm going to go a little bit more upon what I touched upon, little more about than what she was telling. See, the convention have been ultrasound, MRI, then it became tomosynthesis and a combination of mammography together. See, this is how you normally see a picture. But then when you go for more automation or artificial intelligence systems, the standard picture, the median element of is differently studied, the squiness, the kurtosis, the entropy. Entropy is something thermal, that is what is status, and the fractal dimensions. So when see a normal image, what is seen in the first column by your own eyes can be machine mediated with so much of breakthrough, and then once you
Audio, no audio.
Virtual eyes are prone to miss. It is I hope I again got disconnected. Very sorry for that. I'm sharing the screen again. I'm already halfway through. Let us finish fast. So that is how the radiomics work for the definitive influence, or it helps the surgeon to decide. So what is the science? It is very, very simple. It is a mathematical arrangement. No need to worry. It is a system-based environment. One could see it is a definition of the ratio between the number of correct assessments and the total number of all assessments. The most important message is a conventional MR spectrography can give you all the information, but then to make it more scientific, the receiver operating characteristic curve is separately made, and of your patient, the amount of area which is under the curve. See, if it is less than 70% under the curve, then it generally does not work. But if it is in the 80 to 90% or above overlay, it is more than specific. Then we move on to something totally different what we have been discussing so far. This is as old as Hippocrates. Let food be thy medicine and medicine be thy food. The same thing was also told by our own Tamil poet Thiruvalluvar. Food, lifestyle definitely plays a very important role. Now I'm going to talk about something about lifestyle after getting cancer. It is not before getting cancer. It is going to be after getting cancer. One should very, very clearly understand a survival variance is not chemotherapy dependent or surgery dependent. A physical exercise, people moment they are told they're having cancer, they stop their physical exercising, they stop their physical activity. But then it is very, very clear, people who has a minimum balance of 6+ metabolic equivalent of work, which could be anything possibly, walking, cycling, or any standard thing, but a continued effort improves their survival as high as 27 to 30%. That is a huge number to talk about, but it works. So please, please, please help your patients, whatever be their specialty. Moment they are diagnosed to have a cancer, even if never exercised in their life, please put them to the exercise. It is going to increase their survival. Now I'm going to move little more intricate affairs, more in-depth affairs. See, a microbiome is a complex play of organisms, which is more than 6 trillion, which is existing from the mouth to the anal canal. The first feed given by the mother to the child is the first initiation of microbiome to the gut. The child's gut is absolutely sterile or virtually zero microbes, at least at this point of time. Once the first feed is taken by the child, it is not the colostrum, the suckling, latching, everything contributes to the microbiome. So, in general, it is influencing the host metabolism, it influences the digestive capability, and it also influences the immunity. Now you are going to question me, okay, that is going to happen in the childhood, but be aware what happens at birth matters so much when there is an ongoing breast carcinogenesis. I will touch upon a very brief knowledge about the science, what is behind it. This is something called estrobolome. Don't worry, anything which is too complex becomes ohms. When you don't know, you end up telling ohm. It is like radiome, microbiome, estrobolome. Estrobolome is something, the ovarian hormone, the biosynthesis of ovarian hormone happens in the ovary. Then it becomes circulating estrogens in the bloodstream, where when it goes to the liver, it happens the phase 2 of conjugation of the circulating estrogen. What really happens is the UDP glucuronide transferase breaks down into two. What happens? Some part goes to the urine and gets out, but a predominant part goes to the intrahepatic circulation. What really happens is how estrogen influences, it directly has an opportunity to interplay with the gut bacteria, and eventually when there are some gut bacteria where it helps the body to reabsorb the estrogen. There are some gut bacteria which is going to be detrimentally working against the system by not taking up the estrogen. So eventually, that is why you have an increased risk of breast cancer in postmenopausal women due to lack of estrogen in the cyclical estrogen. That is why some or predominant cancer of the breast happens in the perimenopausal and postmenopausal period. So this may be a one important predictor whether a woman will need a hormone supplement after the menopause. Sorry for this busy slide, but let me make it very, very, very easy for you. See, imagine this is the microbiome which is seen in a normal breast tissue where everything happens inside. You have the entire gamut of microbiome. The common thing is Bacteroides, Bifidobacterium, all those things. Where all it can happen? It can happen inside the lactiferous ducts. It can happen in the lymphatics. Where all tubes are there in the breast, you can have organisms there. But then what really happens here is moment the basal membrane is breached, whether the moment the breast endothelium or the lining gets broken, all these harmonious substance gets broken out into the system, eventually spilling off all the microbiomes into the blood circulation. That is why some people do not follow the TNM concept and end up having skeletal metastasis because the entire tumor is spilled into the blood circulation, or it is also driven with the positive and negative interference with the microbiome. So here one could appreciate already we have adequate research. What are the probiotics which are going to help to suppress the cancer, and what are the downplaying? Downplaying in the sense it rapidly enhances the growth of the breast cancer tissues. But again, please wait. Now they have postulated last 7 years work is happening. I am sure a definitive probiotic is going to come very soon for a breast cancer, where people are going to be given probiotic from the day they are going to diagnose. A very, very simple, very heartening solution is our Indian owned system: eat curd rice, drink buttermilk every day. That is the best thing which is being studied by the global research centers. So the Indian way of eating curds, Western way of eating yogurts, this is going to be a life changer. It is another reason to enjoy your curd rice and buttermilk for every day. Then this I will touch upon very briefly. This is definitely a too technical stuff. So the tumor microenvironment. What happens is, see, it is like how IMA works. There is a president, there is a secretary, there is a treasurer, there is an executive body, women's wing secretary, Quaker is. So it is an integrated one. As long as it is an integrated unit, IMA Chennai South functions well. Somebody is pushy, somebody is slow, somebody does not do anything, somebody is very active. So all these things are interplayed by very many factors. You should have free time, you should have the willingness to work, and you should be oriented towards your position. That's how you make a more successful post folder. Same thing happens in the tumor and microenvironment. It's a totally heterogeneous ecosystem where who all live: cancer cells live, fibroblasts live, adipocytes live, endothelial cells live, mesenchymal stem cells, and extracellular matrix. Again, exosomes are the structures which are inside the cell, out of the nucleus, inside the cell membrane, where it is the one which is going to drive the cancer progression, angiogenesis, or the entire sequence of metabolic activity which happens in the cancer progress. Don't get worried about this slide. This is the amount of molecular work which is happening at this point of time, starting from diagnostic applications, starting from prognostic application, response to therapy prediction, identification of non-understanding the more important system. Let us not worry about this slide. I will simplify this for you. So the molecular subtypes are importantly the luminal A, luminal B, are the HER2 type, and the basal like triple negative cancers. So that is how they are fundamentally molecularly subtyped at this point of time. Then comes the important one. We move on to the next molecular target. The microRNA or the messenger RNA fragments are the important ones which govern the entire metabolic pathway. What happens? Cellular biogenesis, abnormal transcription control, and then what really happens is the signaling pathways. Hey, come on, now we get a WhatsApp. The executive committee has a WhatsApp. You have a communication WhatsApp. But then how fast the message reaches
and then how fast people respond back. There are always responders, there are some delayed responders, and many are non-responders. Same thing, but then the signaling is one platform of WhatsApp, and that is where when you get dysregulated, the epigenetic modification makes the tumor cell very lucky. There is no controlling mechanism. They go haywire and start multiplying, and you have a huge lot of microRNAs and the messenger RNAs which work on the signaling of cancer. And defects in the RNA, microRNA, it blocks the biogenesis and it affects the normal function of the cell, eventually making it to poor malignant potential. Don't worry about these numbers. These are going to be coming up soon, where personalized medicine are going to look into it. What are the types of microRNAs which are upregulated, and what are the types of microRNAs which are downregulated, going to drive the future individualized medicine and the precision medicine approach. So, for your convenience, I make it more and more simple. MicroRNA can help you in diagnostic status, prognostication. They can be working as adding up to the predictive biomarkers than your core biopsy. And then there can be therapeutic targets which gives you where all it upregulated, you rectify that. Where all it is downregulated, you derectify it. And then at this point of time, the onco microRNA group and the TS microRNA expression, these are the principal set of components. What really happens is they escape apoptosis, eventually make a cell, malignant cell, eternally viable, thus escaping our therapy basis. So please be aware, your future therapy is going to be driven on more important factors. Then we want a little more important thing, which already has been spoken by few, the BRCA1 and BRCA2. Please understand, you see a breast, apart from what all I've told, they need to be re-stratified in the form of pathological characterization, epigenetic characterization, in addition to the genomics. We'll look into it. So where are we heading? So it is going to be crosstalk between genetic screening. Then comes your germline mutations to stratify. Now we have understood, or we have tried to understand what has been the driving factor for malignancy. But now, am I, or will I get a breast cancer? Will my daughter, will my spouse, will my grandchild get a breast cancer? That is where the germline mutations are being studied to stratify people who are at high risk of cancer. Whereas somatic mutations profiling help the tumor genome, who will benefit from which therapy, or which patient can give the right therapy to get the maximum out of the care. So the most important one, this point which is operational and functionally useful, the breast cancer gene 1 and 2, when they are directly dependent on the DNA repair of the damaged cells. If there is a definite possibility of 10% of them getting a breast cancer. This is where the role of prophylactic mastectomy comes. Once there is a mutational presence of these both the things, then they end up having a prophylactic mastectomy. So I'm sorry about that. So one could say this is yet another important transformation which is already the world is getting benefited, and celebrities like Angelina Jolie and important royal families are coming up with this spread of the message of prophylactic mastectomy. Now we move on to last few issues. So for all reasons, breast cancer from time immemorial has felt it is suffering, toxic chemotherapies, and then you are doomed to have an impending fatality. From there, we have already come, we have a better understanding, we have better appropriate therapy, we have an individualized approach, and we are definitely working more towards cure. And are we winning? It looks like that, and I'm sure the future is very bright for all of us to win the breast cancer. Thank you for your patient attendance. Thank you for the opportunity given.
Thank you, Dr. Kanagavel, for an elaborate journey through history and the newer modalities available, the genetics and genomics, what are the new things available, the way forward, and the prophylaxis. It's a wonderful feast indeed.
Thank you, madam. Thank you for the opportunity given.
Yeah, thank you very much, sir, for your wonderful talk. Now, vote of thanks, Dr. Sampath Kumari.
newer modalities available, the genetic.
Madam, yeah. Okay. Thank you everyone for being part of this program today. There were wonderful lectures from all the stalwarts today. I thank each and every one of you on behalf of IMA Chennai South.
हिमाचल यमुना गंगा उज्जल जलधि तरंगा तव शुभ नामे जागे तव शुभ आशीष मांगे गाहे तव जय गाथा जय गण मंगल नायक जय हे भारत भाग्य विधाता जय हे जय हे जय हे जय 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 हे.
Thank you, madam.
Dr. Kanagavel, fantastic talk.
Thank you, madam. Thank you for the opportunity, madam.
Thank you. Opportunity.
Thank you.
Thank you everybody for this
But
wonderful
anyway,
program today. Thank you, Kanakavel, for giving me this opportunity to call so many people, and then everybody did their job very well today. And I thank our president, our treasurer, and everybody in all the members for giving me this opportunity to conduct this program. Thank Kanakavel for all the support. Thank you all. Thank you very much.
மேடம் சாந்தா மேடம் இப்ப நல்லா ஆயிடுச்சு அவங்களுது. முதல்ல மக்கார் பண்ணிட்டு இருந்தது
என்னது
மேடம் நாலேஜ் வேற வேற எல்லாம் சரியாயிடுச்சு மேடம்.
என்னது
அறிவா இது Zoom உங்களோட வீடியோவா
உங்க ஆடியோ வாஸ் வெரி சேலஞ்சிங் மேடம். இனிஷியலா கேட்கவே இல்லைங்க மேடம்.
இல்ல சார், நான் என்னோட இப்பதான் ஒர்க் பண்ணிருக்கேன். இது சாஃப்ட்வேர் போயிடுத்து.